You see, I was talking to one of my friends and asked him, buddy, how many streams of income do you have? He said, two. You see, I was talking to one of my friends and asked him, buddy, how many streams of income do you have? He said, you see, I was talking to one of my friends and asked him, buddy, how many streams of income do you have?
Good morning, one and all. Offering our humble pranams to the lotus feet of His Holiness, Jagat Guru Shri Shivaratri Rajendra Mahaswamiji, and seeking the blessings of His Holiness, Jagat Guru Shri Shivaratri Deshi Kendra Mahaswamiji. I, Dr. Kavya Upadhyaya, on behalf of the organizing committee, heartily welcome all the dignitaries, guests, speakers, delegates, and the media personnel to the two-day National Conference on Nutrition, NUTRICON-2022. This conference is organized by the Department of Community Medicine, JSS Medical College, Mysuru, in collaboration with the Department of Studies in Food Science and Nutrition, University of Mysuru, and Department of Nutrition and Dietetics, School of Life Sciences, JSS Academy of Higher Education and Research, Mysuru. At the outset, I also extend our warm welcome to our technical partner, CoGuide, our digital partner, Code Flurry Technologies, our print partner, The Rangu, and media partner, Pratinidhi Patrike. Without further delay, let us begin with today's first technical session, which is Nutrition through Life Course Approach. We have three eminent speakers who will be taking you through this technical session. Firstly, I would like to welcome the chairpersons of this session onto the dais. Dr. Suma M.N., Vice Principal, Preclinical, JSS Medical College, and Dr. Suma K., Professor, Department of Obstetrics and Gynecology, JSS Medical College, will be chairing this session. I welcome Dr. Suma M.N. ma'am and Dr. Suma K. ma'am. Over to you, ma'am.
Very good morning to all. NUTRICON 2022 has been started today. Yesterday was a pre-conference workshop. We are going to start technical session 1, Nutrition through Life Course Approach. The spectrum of nutritional problems vary across different stages of life. The childhood, the elderly, and the geriatric age group. And we have seen many special nutritional problems which require specific nutritional interventions. To enlighten these aspects, we have three eminent speakers who are experts on three stages of life. So now I welcome all three renowned persons on these who have worked on these three different stages of life. I welcome Dr. Savita M.R., who is Professor and HOD, Department of Pediatrics, Mysore Medical College and Research Institute, Mysuru. She has done MBBS from Government Medical College, Mysuru, and MD Pediatrics from Bangalore Medical College, and DNB Pediatrics, and she has done Diploma in Allergic and Asthma and Postgraduate Diploma in Hospital and Health Management. She has 23 years of experience in this field, and she has worked as Chief of Nutritional Rehabilitation Center at MMC for 7 years. And she is course coordinator for integrated MSc, PhD, and nutritional biology students at CFTRI Mysore. And her field of interest is asthma in allergy and children. She has presented 61 papers in various indexed national and international journals. She has 54 papers in various state, national, and international pediatric conferences. And she has given various talks in state, national, international conferences and written various chapters in books. She has been principal investigators in ICMR funded project to her credit. We welcome Dr. Savita from Mysore Medical College and Research Institute. And over to you, Dr. Savita.
Thank you, ma'am, for that introduction. And at the outset, I would like to thank the organizers of My NUTRICON for having invited me as speaker for the conference. So, can I have the projection? I've shared, I think. Can you just show? Yeah, they will know. Okay, so we are going to discuss the pediatric aspect of nutrition through life course approach. So I shall be discussing my topic under these headings: normal pediatric nutrition across childhood and practical aspects of malnutrition in children. And I will share my experience of running nutritional rehabilitation center at our institute. So nutrition across various age groups, starting from birth till 6 months. As we all know, according to WHO, optimal breastfeeding is we should, in all children who are born within 1 hour of delivery, we should initiate breastfeeding. And breastfeeding should be exclusive, not even water, for the first 6 months of life. And we should continue breastfeeding after having introduced complementary feeds at 6 months of age. Breastfeeding should be continued for till 2 years, minimum 2 years, and they can do it for more. And what WHO has described is promotion of all these things, which is called as optimum breastfeeding, saves more lives than any other health intervention. Some people say ORS is the best health intervention of the last century, which has saved many lives. But breastfeeding, exclusive and optimum breastfeeding, will actually is the best intervention, even more than ORS, in saving lives of children. And before the child is given first breastfeed, parents generally give some pre-lacteal feeds. The scenario in this part of our country is people give sugar water, they'll give honey, they'll give cow's milk and all these things. So this should be strongly discouraged. We should not allow these things because The first few days, whatever the mother has secretion is called colostrum, and it is very important for the child and protects against infections. And in fact, it is called as colostrum is the first immunization for the child, even before the BCG vaccination is given. And also introducing these prelacteal feeds is a source of infection. So you should always strongly discourage prelacteal feeds. Whenever we tell, okay, mother, okay, you breastfeed within 1 hour, and it's not that we walk off, especially primary mothers need to be taught about how to breastfeed, because for optimum suckling, 2 things are very important: proper positioning and proper attachment. What is proper positioning? The right one is the proper positioning, and this is improper positioning. What is proper positioning? You can see the entire neck, back, and the body is in a straight line, and the entire body is supported. Baby is facing the mother, and baby is close to the mother. These points should be there, and we should stress the mother for good positioning, which will promote optimum suckling. Next is the attachment, wherein this is correct attachment, this is poor attachment. Attachment means mouth should be wide open, lower lip everted, areola above may be visible, and the chin should be touching the breast. So this good attachment promotes effective suckling and also prevents injury to the nipple. So it's not that we just tell go breastfeed the baby in 1 hour. We should also tell the mother these subtle things like don't give prelacteal feeds. There should be appropriate positioning. There should be good attachment. Now, most often the mothers want to know how often I should breastfeed my child. So it is called on-demand feeding whenever the baby cries, and minimum 8 feeds per day should be given, and including night feeds. That is because in the night prolactin secretion is more, so they have to feed even in night. And then most often we don't know how much the mother is secreting, how much child is drinking, and mothers are apprehensive, grandmother is apprehensive. They don't know whether child is getting sufficient breast milk or not. So we should tell the mother these things, that if your child is adequately breastfed, he will pass urine 6 to 8 times per day, and he'll sleep for about 2 hours after a feed. And after the first 10th day of life, they start gaining weight at the rate of 20 to 40 grams per day. So it's not only initiation of breastfeeding, these subtle things like don't give prelacteal feeds, good positioning, good attachment, and how to know that my child is getting sufficient breastfeeding. This counseling should be done to mothers. Now, 6 months to 2 years. This is a very typical age group where improper complementary feeding will cause malnutrition in the child. So, how a mother should start complementary feeding after 6 months of age. So, this table is telling everything about complementary feeding. So, in a 6 to 8 months old child, apart from the normal breastfeeding, the mother should give extra 200 kilocalories per day. Then what she should give? She should give thick porridge. Like what we said, what is thick porridge is if she holds, like she should make it like a payasam. So when she drips it, it should not flow freely. It should be thick like a payasam. It should go very slowly. So we always say ragi sari in this part of the state, because ragi sari is an amylase rich food, especially when they sprout and prepare ganji with that. It promotes digestibility for the child. So thick porridge and well mashed foods, something like very soft vegetables and fruits can be introduced. And this, how many times they'll feed? 2 to 3 meals per day. And in between 1 to 2 snacks. Snacks doesn't mean Lays, Kurkure like that. So snacks means fruits, so small fruits, chapati soaked in milk, something like that we need to introduce. Never junk foods. How much to give? Start with 2 to 3 tablespoonful per feed and increase gradually to half of a 250 ml cup. Now, after that, 9 to 11 months of age, gradually the calories should be increased to 300 calories per day. 6 to 8 months, they were giving 2 to 3 meals per day, increase, make it 3 to 4 meals per day, along with 1 to 2 snacks. And here you can give half of a 250 ml cup. Then after 1 year, they can take most of the family food, but it should be little bit mashed, slightly mashed or chopped. And this again 3 to 4 meals per day they can give, and they can go for a full 250 ml cup. And always how the mother feeds is also very important. These days we see the mother having put on the Cartoon Network on the TV and just she's pouring something into the mouth of the baby. This is not going to help. Feeding time is something very interactive between the mother and the child. So she should keep the baby on her lap and wash her hands and the baby's hands. So because in between he'll putting his hand into the food, and with loving care, she should feed the baby, not pouring something into the mouth of the baby when he's watching Cartoon Network. Now, about 2 years, how should be the nutrition? So we all know this food guide pyramid. So basically, they can take all family food, consume adequately the cereals and the pulses, adequately, then eat liberally the vegetables and the fruits, and moderately the non-vegetarian food, egg and all that, very sparingly the sweets and other things. And very important, it's not only the diet. The exercise is very important. Exercise minimum half an hour per day for children is very important. And adolescents these days, pediatric age group is still 18 years. So I'm talking till 18 years. So we have seen that these days the adolescents are into smoking and alcohol, which should be avoided. And the present generation they have made this pyramid upside down. They are eating more of sweets, chocolates and junk food, and they are eating sparingly the carbohydrates. It is not healthy. That is why our country is having now a dual burden of malnutrition, which I'm sure all of you nutritionists will know, that we are on one side having malnutrition, on the other side having overnutrition and obesity amongst urban adolescents because of wrong lifestyle habits. So again, this is another simple way of telling the mother that imagine this is a thali of a child. Half of it should be vegetables and fruits, half should be milk, and half should be milk, egg or dal, and half should be, quarter should be milk, egg and dal, and quarter should be rice or chapati. Again, this is an RDA for Indians by ICMR 2020. What I want to stress here is, as the child grows, you can see that the protein requirement, say for example, in a boy of boy 13 to 15 years, he needs about 45 grams of protein, almost like a adult male. So that means adolescents require more proteins. So we need to tell them more proteins because they are gaining weight, putting on muscle mass. Similarly, iron, you can see that a girl who is say 13 to 15-year-old will need almost say 30 mg of iron, whereas a female needs about somewhere 29 mg of iron. She needs almost like a female, slightly more than a adult female. Again, here anemia is very common in adolescents. So they require more proteins, more iron, then zinc for bodybuilding. Almost it is like in the adult range. You can see 14.3 or 17 in adolescents. So this is more than adults. So they require more proteins, more iron, more zinc. And then calcium. Calcium also adolescents almost like an adult, 1000 mg per day after 13 years of age. And very important is vitamin D. Vitamin D, because after 1 year of age, all will require the adult requirement of 600 international units per day. So the protein, calcium, iron, zinc, and vitamin D, we need to stress on adolescent nutrition. They need to take sufficiently. In fact, for up to 1 year, we give vitamin D supplements for children. Now, considering these things, let us see malnutrition. Though malnutrition means both undernutrition and obesity, I am concentrating mainly on undernutrition. As you all know, we have something called as severe acute malnutrition, wherein the criteria is weight for height less than -3 standard deviation. Same thing, if it is between -3 to -2 standard deviation, it is called moderate acute malnutrition. Moderate acute malnutrition. Next, mid-arm circumference less than 11.5 centimeters. If it is between 11.5 to 12.5, we call it as moderate acute malnutrition. Then edema of both feet. These three are the criteria to say SAM in children. Now, let us see, this is a NFHS 5 data between 2019 to 21. What is the prevalence of less than 5 years wasted? This means, moderate acute malnutrition. Nearly 19%, that is almost 1/5 of our children in India are having moderate malnutrition, which is a very high figure. Every 5th child is having moderate malnutrition. Nearly 8%, almost a 6th child is having severe malnutrition in our country. See the prevalence of anemia, 64%, very high prevalence. Almost every other child whom we see in our OPD or every other child in school is having anemia. So malnutrition can kill the child. Anemia can also predispose the child to infections, reduces school performance, reduces activity. Almost Karnataka and Mysore is almost having similar data. And this is urban and this is rural. So there is not much between difference, though slightly rural prevalence is more. Now, coming to the typical clinical features, you can see the typical hypopigmented hair changes as part of kwashiorkor. This is a child whom we had with us with the extensive the skin changes of kwashiorkor. And this is a child with bilateral pedal edema, again kwashiorkor. And they are prone for Bitot spots producing night blindness due to vitamin A deficiency and angular stomatitis B complex. The associated other deficiencies they will be having. This is again a child we had. This child was a migrant from North Karnataka and he had severe vitamin A deficiency and almost melting of the cornea because of vitamin. He is going to be blind. So these things are the consequences. Then this is a child with rickets. You can see the costochondral beading, the widening of the wrist. These are all features of rickets which we see due to vitamin D deficiency in malnourished children. Then we did a study and we also published the study regarding what are the risk factors for malnutrition in the children who are admitted to our NRC. We saw that children less than 2 years are more prone for malnutrition. Younger mothers, we compared cases with malnutrition to controls without malnutrition. Younger mothers, children more prone to have malnutrition, and more number of family members, more risk of malnutrition. Sorry. And again, poor socioeconomic status, more number of siblings, more risk of malnutrition. Lesser the birth spacing, more risk of malnutrition. More the birth order, more risk of malnutrition. And toilet facilities were not seen in children with malnutrition at their house. And again, living conditions were poor in children with malnutrition. And exclusive breastfeeding was not done in nearly 42% of children with malnutrition in the first 6 months of life. And effective complementary feeding was not started. I mean, complementary feeding was started prematurely before 6 months in nearly 70% of children with malnutrition. And most children were bottle fed in the malnutrition group. So, of course, calorie protein deficit were more. So these are the standard well-known risk factors which we need to tackle in malnourished children. Malnourished children are prone for these important complications like infections, infestations, hypothermia, hypoglycemia, sepsis, anemia, and other micronutrient deficiencies, cardiac failure, because cardiac atrophy of the muscle fibers, they are more prone for fluid overload and cardiac failure. Fluid and dyselectrolytemia, very common with diarrhea, then lactose intolerance. Of this, pneumonia can kill the child, diarrhea can kill the child, hypoglycemia, sepsis, all this can kill the child. So this is one of our patients who had a severe malnutrition, which went undetected, and later the pneumonia also, they didn't bring the child to the hospital. So he landed up in empyema, that is covering of the pus all around the lungs. And we have put a tube around the lungs, and you can see the pus draining here through the tube. So this is a severe complication of malnutrition. This is again another child with pneumonia who has come in a very late stage to our hospital, who is intubated. He is presently in our hospital and he is intubated and on ventilator. Then lastly, comorbidities. Again, in our study, the common comorbidities were pneumonia. We have published this: diarrhea, sepsis, meningitis, and anemia. These were the common infections which we saw amongst our children. Now, we run a nutritional rehabilitation center. So lastly, I want to share my experience of running a nutritional rehabilitation center and what are the limitations we are feeling. So what is a nutritional rehabilitation center? It is run by NRHM, wherein children with SAM and MAM are admitted and managed. In Karnataka, about 32 NRCs are there at district level, and they will have a trained medical officer, a staff nurse, diet counselor, cook, and attender, and social worker. What do we provide? We provide 24 hours care, treatment of complications. We prepare food there, like F75, F100 milk, and we prepare diet for the child. We have a kitchen where the mother is also involved in cooking, and she will be taught about correct feeding with locally available foods, and we give food for these children. They have a play area, and we provide counseling and demonstration and practice of energy dense food, and follow-up of these children was also done at NRC. This is our NRC at Mysore Medical College, and these are the patients admitted. And we have a play area wherein they will be playing there. We have toys for these children, and this is our kitchen where they cook food for children and they feed them, and mothers are involved in cooking so that they learn how to cook with locally available foods in a helpful way for the child. Now, I just wanted to share our data of NRC just as an example of the past 1 month. So what you can see here is, I don't know if it is visible at a distance. What you can see is last month data. So what you can see is that we have a total of 33 admissions in the last month, in the month of November. Of that, 14 are moderately malnourished and 15 are severely malnourished. And this is a very important chart. What I want to stress here, of the 33 cases, all the 31 cases were referred from our ward, emergency ward. Only 2 cases are referred from the frontline worker like Asha and Anganwadi worker. What does it indicate? These children are going undetected in the periphery, and once they are becoming sick with pneumonia, diarrhea, severe, they are coming to us. At that time, we are picking up malnutrition, which should not be, which is not correct. We should have picked them up and prevented them from going into complications like pneumonia and diarrhea. We are picking them at a stage wherein I showed those photos wherein they are so sick, they have come with empyema and on severe pneumonia and on ventilator. So peripheral referral for us is not that good, though of these days it is picking up. Another thing what I want to say is majority are getting discharged within 7 days. Of the 33, 11 got discharged within 7 days. It takes about 2 weeks for them to gain weight and all that. What happens is once they are out of pneumonia, the parents want to just go off. Engu jwara vasi agide, everything is okay, we'll take him home. They are not, because they have some social constraints and all that. Now government is actually giving them wage compensation. Means per day they'll get 259 rupees for the loss of their wages to prevent this premature discharge. This has brought down discharge to a certain extent, but still they are getting prematurely discharged. And then next, again, I want you to see here one thing, that children who are due for follow-up is 112. Of that, only 75 are followed up. So many, nearly 50 are left unfollowed up. And what is happening is one child has come with relapse. Almost 5 have come with readmission because of again pneumonia and these things. That means what? Follow-up is poor. Because of that, they are getting relapse and they are getting readmitted. This is the problem. Mainly community follow-up and community picking up of cases needs to be strengthened in our state or country, so that they don't come back with severe complications. So in conclusion, I want to say that pediatric nutrition is the most important aspect of nutrition across all age groups, because the child's brain is growing in the first 2 years of life maximum. Next is the next up to 5 years. After that, it doesn't grow. So if there is malnutrition in the first 5 years of age, then his brain growth gets affected. Initially, we had this concept of brain sparing. Now that is disproved. Brain is the most vulnerable organ for malnutrition. So, and the child is more prone for further complications. So pediatric nutrition is very important. And the burden of malnutrition, we saw every 5th child is moderately malnourished. Every alternate child is having anemia. So the burden of malnutrition is still quite high in our country. And lessons from our NRC is what we feel is active case finding in the community is lacking. And also poor follow-up is there of malnourished. It is picked up. I have been in NRC for 8 years. What I was seeing 8 years back and now it is picked up, but still a lot needs to be done. So with this, I would like to conclude my talk. Thank you one and all.
Thank you, Savita madam. It was very good presentation. You have highlighted about the importance of breastfeeding, especially the duration, positioning, and the very important ones to check the adequacy of breastfeeding, which definitely most of them will not have given emphasis on this. It was very good. And the services that is rendered at your nutritional rehabilitation center is really appreciable, madam. Congratulations to you on this. And now it is open for questions. Any questions? Yeah.
Thank you, ma'am, for a wonderful presentation. I know we had also visited NRC and a very good job done by your department and MMC. I have, this is just in addition to what you shared with the data on NRC children. So they go undetected in the field. So the question is there any relation with the SNCU graduate children landing up in NRC? What is the amount of those children who are landing up? And what are those children who are premature at birth or having low birth weight? They are ending up in NRC. Is there any, the majority factor is because of that, or during the process they were normal and then they were there? So what is that proportion?
Yes, sir. Sir, we have 2 categories of SNCU graduates. One is preterm, appropriate for gestational age. They might have been born at 8th month, but if they are appropriate for 8th month, if their intrauterine growth is appropriate, with exclusive breastfeeding and we give them supplements, we do SNCU follow-up of these graduates, they are not landing up in malnutrition. But there is a category called SGA, small for gestational age. Suppose they may be born a term only, they would have completed 9th month, but their intrauterine growth is affected because of various reasons, most important being maternal malnutrition also. So in that category of patients, the picking up is bit slow. So these children are known to land up in future malnutrition. In that also, again, there are few things like in which part of the gestation there is the insult. If it is in the first trimester, the body cells are getting formed in the first trimester. So if it is in the first 3 months, then it is called symmetric IUGR, where the cells number itself has become less. So they may not pick up also later. Whereas if the insult is something in the later half of the gestation, where the number is there, size of the cells is less, so they will pick up. So if it is, they are called asymmetric IUGR. So if it is the insult is in the first trimester and they are symmetric IUGR, then they have a poor prognosis for picking up. We do get like term small for gestational age babies. On an average per month, we get about maybe a rough figure is around 10 babies per month. And that is because ours is a referral center. So we do get such children also, and they take a longer time or may not pick up also.
Thank you, ma'am.
Thank you.
Yeah.
Good morning, everybody. Thank you, ma'am, for the presentation. Well, I have a question with respect to, in the last part of your presentation, you mentioned about malnutrition affecting brain development.
Yes.
So I was just wondering, does that affect their cognitive abilities as well?
Yes, yes, ma'am. So they have
Later
found that initially the concept was brain sparing. That means they said, okay, the other parts of the body will be small and all that, but the brain is spared. But now they are telling brain is the most vulnerable organ. So they have found that the arborizations, between the dendrites and then the myelination, all this occur in the first 2 years maximum, and then later. So they have found that this is going to get affected in severely malnourished children. So that is pathology wise. So how it is going to affect the child's school performance is going to come down. The mathematical calculations are going to come down. The memory is going to come down, and like the subtle things which are very important for growth of the schooling of the child, that is, they have found that is going to come down in these children. So it's been proved pathologically also.
Thank you, madam, for the wonderful presentation and discussion. So moving on with the session with nutrition through life courses, I would like to invite the next speaker. I really feel proud and privileged to introduce to you all Dr. Vidya Thobi, a well-known obstetrician and gynecologist among all the gynecologists in India. As a former invitation or introduction, I would like to say a few words about madam. She is heading the Department of Obstetrics and Gynecology in Al-Amin Medical College, Vijayapur, Karnataka, and she was the chairperson for Food and Drugs and Medico-Surgical Equipment Committee of the FOGSI. FOGSI is our national federation comprising of almost 40,000 gynecologists. And she is the ICOG Governing Council member, and she is a national corresponding editor for Journal of Obstetrics and Gynecologists of India. And she is the organizing chairperson for the next Karnataka State Obstetrics and Gynecological Society Conference, president of Vijayapur OBG Society in the year 2009. And she is the FOGSI, she has been awarded with FOGSI Champion Award in the year 2019.
And Madam is a postgraduate and undergraduate teacher for the past almost 30 years. She has organized various CMEs, workshops, and awareness programs. And she has presented various papers in national and international conferences. And she has many publications in various journals and contributed chapters in Foxy Focus, and also has been invited as a speaker for national and international conferences. So welcome, I welcome on the behalf of organizing committee for this conference, Madam.
Thank you. Thank you for that, those kind words, and thank you for the invite. And I immensely thank the organizing team for inviting me here. So dear delegates, this is very, very important topic. My previous speaker has highlighted many, many things, and really I'm proud of her studies also. She has done a wonderful work in the nutrition in the pediatric age group. So my part is just before that, that is nutrition in obstetrics, which is very complex one as such. So my contents are really about the preconceptional diet and weight gain during pregnancy, and various things we will be discussing in the due course of my talk. Now, what is the nutrition? Because many community medicine people are here. So I start defining nutrition as a basic human need. We all know, in Marathi, there is a word that is kashasati potasati. So everybody, we earn our livelihood for our stomach. So whatever goes inside should be nutritious. That's what we say. And WHO defines nutrition as an intake of food considered in relation to the body's dietary needs. So that is not sufficient. We should have a good nutrition. So good nutrition is an adequate, balanced diet combined with regular physical activity. I underline regular physical activity here, which is a cornerstone for the good health. So why we are worried about the nutrition? Because we know that poor nutrition often goes in hand in hand. We have seen the corona times, and it is definitely a cause of reduced immunity, increased susceptibility to the disease, impaired physical and mental development, as Madam was talking of cognition and brain sparing, all those effects because of undernutrition. And the fourth important thing is reduced productivity. So we all know that if our brain is not supplied with glucose, we feel lethargic, we have so many other diseases, and that is what we talk of. So in obstetrics, the nutrition provides the substrate, mainly for the development of newer fetal tissues. And this is the nutrition which the fetus as well as mother banks upon as a energy reserve, even in the postpartum lactation. So what we should know is the physiological demands of pregnancy, which necessitates additional dietary requirements. Energy requirement is increased, we all know, by 17% compared to the non-pregnant state. And when we talk of total calorie intake, it varies because some women are thin, some women are obese. So relatively, according to BMI, one should calculate the calorie intake. So it is a very sad affair that now, because of the government program, we know that the immunization has improved, the institutional deliveries have been improved. But what has happened to our nutritional state of a woman? They have done a survey and they found that 22.9% of the women in India enter the pregnancy as underweight. And of course, in urbanization has called obese woman also. Obesity, we know the PCOS and obesity and its complication. And if you see the anemia, it is a huge topic, but 30% of the women, they don't only consume iron and folic acid. And about 50 to 60% of our women, they are anemic. Average weight gain, if you see in the pregnancy, is about 7 kg only. So this is our eye openers for us. Our International Journal of Gynecological Obstetrics and FIGO, that is our international organization, there are recommendations on adolescent, preconceptional and maternal nutrition, and they say that think nutrition first. So we have to think, because the central role of nutrition to determine the health across the life course and across generations. We are thinking of maternal nutrition, but it is always a nutritional deficiency carry on in generation. That's why we call it as a transgenerational, and poor nutrition at any stage has a negative consequences. So why it is very important? This slide is very important because there are effects of these preconceptional and in utero environment on offspring, phenotype, and future health. So if you see the maternal diet and body composition, like glucose, energy substrate, micronutrients, folate, B12 and B6, macronutrient balance, that is carbohydrate, fats, and proteins, and the metabolic status, it has got effects on potential oocytes and embryo responses, potential fetal consequences, and potential long-term consequences. There are epigenetic modification and gene expression changes. There is altered fetal growth rate, altered setting of neuroendocrine axis, and abnormal birth weights. And what are the long effects? As Professor Savita was pointing out, on stunting, impaired neurodevelopment, obesity, and cardiovascular and metabolic disorders. So these are transgenerational, and there are effects on the next generation. This is our known hypothesis, that is risk of various chronic diseases in adulthood, like diabetes mellitus, hypertension, coronary heart disease, it has their origins before birth. So this is a vicious cycle. Even undernutrition and overnutrition both has nutrient-mediated teratogenesis or fuel-mediated teratogenesis. So both have got their own consequences. Now, what happens if the woman is she is undernutrient, she is malnourished? What happens is it has got nutrient demand exceed supply, and there is a fetal undernutrition, as there was brain sparing, impaired development, and even there is impaired development of liver, kidneys, and pancreas, down regulation of the growth, early maturation. There is then cortisol, excess cortisol secretion, central obesity in the future, and coronary heart diseases. So this is what even in undernutrition and malnourished woman can give rise to the transgenerational propagation of these chronic disorders. So these are the various consequences of nutrition. Now, what happens to other factors? So there are effects on the mother as well. So maternal malnutrition not only has got effects in the baby, as well as it has got effects on the mother. There is a hemorrhage is more common, insulin resistance, preeclampsia and eclampsia, that is hypertensive disorders in pregnancy, postpartum complication, preterm birth. And in the baby, there is a fetal growth retardation, restriction, birth defects, low birth weight, fetal and neonatal complications. So there is impairment of the offspring growth and development, and long-term adverse effects on mother and mother's health. So these are the various consequences of malnutrition. So what should be the maternal nutrition then? It should be a healthy, balanced diet. We should have an adequate amount of nutrients, which is essential for the development of a baby, that is a fetus. And it should be not only during pregnancy, we are talking of preconceptional diet, and after delivery, as there are various physiological changes and increased demands for the nutrients. So even WHO has endorsed this, and they should have the proper diet, weight management, and this is important because of the maternal and child's outcome, and it varies according throughout the gestation. So in the preconceptional areas, we always talk of various micronutrients and macronutrients, and preconceptionally we talk of iron, folic acid, vitamin B12, iodine. In the first trimester, again, we talk of giving adequate amount of vitamin D, proteins, and fats. Even second and third trimester, the demands increase, and even in the breastfeeding, the calories requirement is varies according to the trimester and postpartum. So there are critical periods of development of embryos, fetal organs and tissues, and we always aim at appropriate weight gain. And even sometimes we know our Indian women are fed heavily in the postpartum period, and there is again postpartum obesity. So we have to think of those problems of postpartum delivery weight loss also. There are other issues like age at conception, energy balance, obesity, a woman already having chronic diseases or any infections during pregnancy. So the diet also varies. So when to intervene, that is an important question. And it is always a life course perspective from infancy through childhood, adolescent. These interventions are very, very important. And this should be extended continuum with one step before pregnancy can improve the pregnancy and child health. So we should tackle this from the childhood. We know that there are various childhood obesity. Then even in the adolescence, we know that the various adolescent obesity and malnutrition we often see whenever we do the surveys in the adolescents in various school programs. So why it is important, preconceptional care? So it is a special opportunity whenever, of course, we have preconceptional counseling and preconceptional clinics, but how often newlywed they come for the preconceptional clinic is a question. There are critical developmental processes like embryogenesis during very early stage of pregnancy. They are influenced very much by the mother's nutritional status and the nutrient stores. And there should be availability of the various nutrients, especially the critical period starts the first 12 weeks. So this is very important. And the maternal weight gain, underweight, it was associated with preterm birth and small for gestational age babies. Then if the woman is obese, and then increase of hypertensive disorders in pregnancy and GDM, and even we know that operative deliveries, they increase. So we tackle this nutritional risk preconceptionally. The anemia should be corrected. The woman should enter the pregnancy with proper weight loss or weight gain because she should have a proper BMI. So as we know that if the woman is underweight, the risk of preterm delivery increases. And if she's overweight, there is again gestational diabetes. Most important and critical micronutrient we always talk of is a folate and multivitamin deficiency. We know that folate deficiency causes various neural tube defects, and iron deficiency anemia is again increased. There is increased risk of fetal growth restriction and low birth weight babies. So we have to supplement these women with the folic acid. There should be proper education and counseling, monitoring of the nutritional status, and they should take a balanced diet, and which should be a micronutrient dense food. And there should be, every woman should be screened. And if she is detected with gestational diabetes, she should be treated properly. Other existing medical conditions, we all know that earlier the tuberculosis was very prevalent. There are various other micronutrient deficiencies, other medical conditions also we should talk of. We should promote exercise and consumption of iodized salt. This is what I wanted to highlight is, this is not a single obstetrician's work. It is a all combined, it is a teamwork. So we should, what all involved professional are community health workers, then nutritionists, then family doctors, general practitioners, OB-GYNs, and even midwives. So everybody, ASHA workers, everybody should be trained for this various counseling of these women. So what first is assessment is very important, what diet they're eating, what physical activity, and main important is their height, weight, BMI, what is the obesity risk, waist circumference, whether she's anemic, whether any specific nutritional problem she's having, various micronutrient deficiencies she can detect, if she has got chillosis, if she has got various other conditions that should be inquired. And always whenever a woman comes, you should have a discussion points about the healthy diet, about the sedentary behavior. That is most important. And if she's obese, how you are going to counsel about the weight loss? What are the risky behaviors, whether she's having other means tobacco, alcohol, and any drugs she's taking, any environmental toxins which are important. And folic acid, again, is very, very important micronutrients we talk of. So pregnancy is a demanding physiological state. Nutrient needs typically increase, and there are additional nutrients which are required during gestation for the fetus, as we talked of. So weight gain, then during pregnancy, definitely there is a weight gain. And we all know that obesities have various other consequences as well. So we should always track the gestational weight gain. So gestational weight gain indicates the adequate dietary intake by the pregnant woman and adequate fetal growth. So most of the gestational weight gain occurs after 20 weeks of gestation, and it is very, very recommended to gain 1.5 to 2 kg per month, second trimester onwards. Average weight gain for an Indian woman is recommended around 10 to 12 kg, of course. And if there is always a warning signal, if there is a poor weight gain less than 1 kg per month, or excess weight gain more than 3 kg per month, definitely if you have to see whether she's having edema, whether she's having hypertensive disorders in pregnancy, preeclampsia, or any other problem. So these you should always track her weight gain. So every time the pregnant woman comes, we have to check her weight. We know how the gestational weight gain occurs. There are various factors like fetus, amniotic fluid, placenta, uterus, everything. So taken care of all these things, there is a weight gain. So this is how the nutritional needs changes during pregnancy, preconceptional, pregnancy, and breastfeeding. So I'll not go into the details. I'm going to discuss this one by one. But preconceptionally, you advise the woman for maintenance of the weight. Pregnancy, you advise additional calories, and in breastfeeding, you have to add few more calories. So main source of energy we all know is the carbohydrates, that is around 60%, and then comes proteins and fats less than 10% calories, along with the other important micronutrient supply. So total energy requirement is 300 kilocalories, and if the woman is heavy worker, the requirements are little more, whereas sedentary worker, it is less. So extra calories, first trimester 85, second trimester 285, and third trimester you add upon 475 kilocalories. Now, how to calculate? That is a bigger question. When any woman comes, you have to calculate. Means a woman comes, how you are going to give her prescription of nutrition. Every time we cannot afford to have a nutritionist or somebody at our in the side of our clinic. So many of us, we follow this. That is total energy requirement is equal to basal metabolic rate into physical activity level. So what a basal metabolic rate for an adult female from 18 to 30 years is 14 into body weight plus 471. And from 30 to 60 years, of course, geriatric madam, she will be talking, the requirement becomes less. So pre-pregnancy body weight should be taken into consideration whenever we are calculating the requirement. So this is just an example how to calculate. So we have to take into account of physical activity level of a woman. So these are the various key nutritional intervention what we talk of. So this is a FIGO's nutritional checklist. So everybody should have this checklist at their doorstep, and you have to take a proper history. And this is available at the website. You can go through. I will just highlight. First is the nutrition assessment, or any medical officer, any community health officer can check this. Second is you have to counseling is very important. Classification of nutritional risk is important. And then the actions on this nutritional, whatever risk factor is very important. So how to classify the nutritional risk? A woman can be short, she can be young age, then she has low BMI, very low mid upper arm circumference, she's obese, there is appropriate gestational weight gain or less than that, you have to classify accordingly. Then check for any coexistence of medical illness, whether she's anemic, whether she's having hypertensive disorders, malaria, tuberculosis, everything, and then you have to give the prescription. If she's obese and overweight, you have to calculate her caloric requirement, whether she's having gestational diabetes. We know that medical nutritional therapy is the cornerstone of starting stone of any gestational diabetic woman. So if she's obese, you have to advise what she should eat and what she should not eat, like chips and fries and all she should not eat. And she has to take small meals, don't eat fried and sweetened item, and she has to get her regular blood and blood pressure, blood sugar checked. So if she's underweight, again, she has to modify her food accordingly. She has to, she should not eat tea and coffee, and regular weight records she should maintain, and she has to take additional calories from sweet cereal, pulse premix or laddus, besan laddu, or additional ghee. Like that, she can modify her food. Now, this really helps in calculation of calories, and we know about the food pyramid, what to eat, what not to eat. And there are, we know that 6 food groups, and from that they have to choose the various food groups. Now, trimester wise, we can advise in first trimester, eat at least 2 full meals, in second trimester, 3 full meals, and in third trimester, again, she can modify 2 snacks additionally. So after calculation and all, what are the important things we talk of is the macronutrients and micronutrients. Because of paucity of time, I will not be going through each and every slide, but at least we should know what are the important macronutrients one should have. So we always talk of energy-rich foods, bodybuilding foods, and protective foods. Energy-rich foods are carbohydrates and fats, bodybuilding are proteins, and protective foods are always vitamins and minerals. So we should have a planning healthy meals. We know about the pregnancy plate, and the pregnancy plate is requires fruits and vegetables, carbohydrates and proteins, and in the small amount fats also. So we always call Anna He Purna Brahma, and these are the various carbohydrate source we know. And during pregnancy, it is around 175 grams per day. And carbohydrate protein intake should be adequate to avoid the decrease of the gestational weight gain. But one should always remember that all carbohydrates are not same. So carbohydrates are digested and absorbed at a different rates. The glycemic index indicates how quickly certain foods raise the blood glucose levels compared to the glucose, which has value of 100. So we have to think of this glycemic index and prescribe them according to their diseases, obesity, and if the woman is thin, like that. So we have to modify that. So sugars, they have got high glycemic index, which are simple sugars. So there are various charts available of the glycemic index also. So already I have explained about the diet plan, how you should break about the this one meals, snacks, and remaining breakfast items. Now, what about proteins? Proteins requirement is around 10 to 35% of the energy, 71 grams per day totally, they say, but that much proteins we are not eating. Actually, Indian women are not at all eating anything. They don't eat eggs, or they don't eat sufficient dal and proteins. So these are the recommended dietary allowances of the proteins. And additional proteins, one has got always fixed ideas in our mind that all non-vegetarian food, they have got good proteins. But even vegetarian diet, there might be some nutritionists in the audience. There are vegetarian sources of proteins. We always forget them. Like we have got almonds, we have got paneer, yogurts, then various dals, lentils and dals, and even stream sprouts. They also have enough proteins there. What about lipids and fats? Every woman should have some fats, because we know that some of the vitamins are fat soluble, so they have to take. certain amount of calories. So in the second trimester, they say around 8 to 14, and third trimester, there are no specific dietary recommendations. So what are the essential fatty acids? They are omega-6 and omega-3. They are necessary for the optimal formation of the brain and eyes. So these are required for the daily diet, and they also help in the cognitive development and prevent allergy. So these are the various sources of fats. So how to reduce the fats in the diet? You should not use less fat in the cooking, avoid frying of the foods, and using low fat dairy products. All those things one should follow, so that the good fats, and there are good fats and bad fats, we should avoid them. Okay. So good fats are omega-3 fatty acids. They always come from the nuts and seeds. So these are the healthy fat foods one should remember. So you use these in your, advise them to use in their diet. So we all know the role of DHA. So fish eaters, they get maximum of FHA. Okay. So I will just skip some of the slides. One should have the fibers, and remember the signal system for the food choices. So remember, this is our pregnancy plate. So micronutrients, always I have touched about the micronutrients, iron, and most important I want to have is the folic acid, as I told. The folic acid, the requirement is around 400 micrograms per day, and these are the various folate-rich foods. Calcium, magnesium, these are the various micronutrients which can be used in plenty in their diet. So you have to advise. These are some of the colorful pictures. Because of paucity of time, I have just skipping some of the slides, but anybody is interested, my slides are available, you can take them. Iodine, we know that it is very important micronutrient, and it always affects the deficiency, affects the concentration, cognitive function, and learning. We know about the various micronutrients and which are very important, like zinc, selenium, vitamin C, vitamin D, and vitamin B. So I will skip them also. And what we should avoid is caffeine and mercurial fish. We should avoid during the lesson. These are some of the obstetric conditions I have highlighted. Just preeclampsia, we advise them 2 gram calcium. There are various studies that omega-3 fatty acids and omega-6 also decreases the incidence of this one. In hyperemesis, when the woman has got excessive vomiting, we can ask them to take low-fat diet, avoid caffeine, as well as supplement with vitamin B6. They say that enough hydration, low sodium diet, even arginine and alanine amino acid can be given in oligohydramnios. Preterm labor can be, there are many studies that omega-6, omega-3 fatty acids can be done. This is just a recommendation for GDM, and remember this GDM plate, this is in gestational diabetes. So you can give these gestational diabetic plates. There are newer initiatives just I wanted to highlight by IAP Health Phone that educate a mother, and they can just talk with the nutritionist what they are eating. So these are the newer one. And just visit this portal. Just I want to highlight, this is a nutrition information, communication, and education portal where you get all the information. So I end my talk that this is a WHO target, that reduction of 50% of the anemia in women in the reproductive age, reduction by 30% in low birth weight, and the rate of exclusive breastfeeding in the first 6 months up to 50%, and reduction by 40% of the number of children under 5 age who are stunted, no increase in childhood overweight, and reduction in the childhood wasting to less than 5%. So this is our target. Let us have, and these are the FIGO recommendations you will get on the website. So in pregnancy, this is a sample diet chart if you want to copy, and we know about the importance of nutrition. There is one more thing I just wanted to highlight is there is an e-course which is launched on maternal, infant, young, child, and adolescent nutrition. And I was a part of this course formulation. So again, they will be launching this. I will inform you. We know about the Poshan Abhiyan, Sahi Poshan, Desh Roshan, and we know about the diversity. This book is available at the website of Foxy, and I was the editor for that. And we got the best book award for this. Here we have highlighted about the nutrition in women across the ages. Thank you very much for the patiently listening. The topic is very vast. That's why I could not complete it properly, I feel. But in the coffee time or any time, I can just, I will take some questions because of paucity of time. I end here. Thank you.
Thank you very much, madam. Actually, madam lecture requires more than 1 hour. So I request all the delegates to, I request madam also to share her slides with the delegates. So due to paucity of time, we cannot allow you people to ask the questions. So madam is available today. So you can have clear your doubts during coffee break or during lunch time. So thank you very much, madam.
Thank you very much. Thank you.
We have a next speaker, known person, Dr. Pratibha Pereira. She is professor and head department of geriatrics at JSS Medical College and Hospital. She has done her post-graduation in general medicine from KMC Mangalore and PG diploma in the geriatric medicine from Malta, IGNO. And yesterday only she has got one more degree, that is diploma in gerontology and geriatrics, international degree. And age doesn't matter. So she's proving that. And her with this qualification, she is doing added responsibilities, like she is mentoring the department, quality department at JSS Hospital. And she is head of the CDSA CCRE, and she is member of ethics committee. She's an NABH assessor and EC member for Cook Dental College. And she is a recipient of Young Scientist Award from API and the Double Helical Award for services in geriatrics. She has won many awards, oration awards, and many publications to her credit. And the one best important thing that I want to tell in one sentence is, every day she visits nearly 4 to 5 houses to take care of geriatric patients. Over to you, madam. Thank you.
Now, it was amazing that we went to pediatrics and before, okay? And then now we are straight away jumping to geriatrics. We are not touched you guys at all. We are allowing you few years of pizza and burgers and KFCs and all of that. So, but then now when I'm talking to you about geriatrics, be aware, by 30, 35, whole greens on your diet, okay? And then see that your diet is good enough so that when you reach the geriatric age, I've got instruction from Praveen, only 15 minutes. So I'll be just going through. Nutrition is very close to my heart, and the nutrition people know I work very closely with them. And all right. So when we look at elderly, one thing is completely neglected is nutrition in elderly. We think elderly people, they have some diseases like diabetes, hypertension, and things like that. Take them, put them on drugs and medications and more medications, but then they deteriorate, they don't improve. You take them, get them operated, they say chest pain, all right. They take them and get a stent put or then do an open heart surgery, but then they deteriorate. And then they get a pneumonia, you give them all sorts of antibiotic, very good, X-ray cleared, but they don't improve. So there is something which understanding is very necessary. So you have to find a way. You have to integrate whatever you're seeing clinically into nutrition and very important, quote unquote, hydration in geriatric medicine. And you have to, now this is an upcoming line. Lot is done by pediatrics, but I'm so happy that I've given an opportunity to talk, because this is a growing field for you nutritionists. Tomorrow you will be wanted by everybody to plan nutrition for elderly. So you have to know what is nutrition in elderly, unintentional weight loss. And as they said, how malnutrition is there in pediatrics, there is malnutrition even in geriatrics. One more thing that you will have to tackle is dry mouth nutrition and malnutrition that causes because of dry mouth and otherwise. You have seen food pyramid, all of it. Now, I want just one question here from the audience. Madams have shown you food pyramid. How is this food pyramid different? Water, exactly. So you see how the food pyramid has changed in an elderly. First thing is you have to have adequate amount of water in an elderly. That's very important. And then, of course, you have balance. You go up. You don't have sweets at all. Do you have sweets here in this pyramid? Not at all. So you have to have, they have written 6 servings. So how will you calculate 6 serving in an elderly? 1 serving is 1 grip. Okay, that you can take in an elderly. His size, his hand, 1 grip becomes 1 serving. So see how this is built up. You first important for an elderly is hydration. Then you go for cereals, and then you take fruits and vegetables, which are important. And then comes protein. And then you add up with calcium, vitamin D supplements. Sugars are totally avoided. Okay. Now there's a new concept that has come. Just like you saw plates. You saw plate in pediatrics. You saw plate for this thing. There is my plate for older adults. And then because why this my plate has come? Because as we grow old, we become less active. Our metabolism slows down. You know, even if you eat 2 Marie biscuits extra every day, you will put on 1 kg in a month. You cannot afford to eat even that. So calculation is so critical in an elderly if you want to keep them in an optimal weight. All right. Absorbing of nutrients. Lot of work is being done on gut bacteria, how nutrients are absorbed in an elderly. So the absorption is a huge issue. And then we do not combine vegetables, grains, oils, whatever we spoke with pediatrics, it is same issue. So it's important to have. So this is your elderly my plate. How different is it plate from pediatrics? What is the difference here? The large junk, what one has to eat. What is the difference in the plate? In a pediatric, what will you give it a good amount? Carbohydrate, okay? But what happens to the carbohydrate as you grow old? You cut down, okay? Your plate contains more of vitamins, minerals and vegetables, very less amount of carbohydrate, and then you put in grains, dairy, protein, everything. So this is my plate for older adults. All right. So we need to calculate. So you have to have an adequate weight. So just like pediatrics, you have to calculate. And madam said, you know, elderly, I will talk about it. Very easy. Height in centimeters minus 100 is ideal body weight. Okay. There are some adults. You'll see many, I wanted to put pictures, but I could not. I said, it's waste of time putting pictures. You'll see very thin elderly. Those who come to your OPD, they don't have any muscle mass, absolutely skinny. Then you have very obese elderly. Just because they are fat does not mean they have muscle mass. They are called as obese frail. Okay. So adequate weight is height in centimeters minus body weight. Now, if you take 150 centimeters and 100 pi, I'll be 48 kgs. That is not adequate for me. I'll become frail. So you have to review this calculation and see that your elderly doesn't become frail. Now, I'm going in for some intermittent fasting. I have lost weight. So everybody says, ma'am, you have lost weight. This is intentional weight loss I did. But then I need to see whether I'm able to climb and my endurance capacity has remained the same. So that is what you have to see. So ideal is, say, you can reduce about 7% of your total weight. And if you're underweight, you have to plan to eat more. So there's a way of calculating calories. Ideal weight into calories. You can take 30 to 50 calories, whatever it is. If a person is very active, like me, I climb 5 floors of JSS hospital. I might have to take 50 calories, but somebody who is sedentary, you can take 30 calories. This is a very crude way of calculating. Now, there's something that has new concept that has come is called as keto food pyramid. That means cut off carbs. Totally reduce carbs in your diet. And that is helping elderly a lot. We do not need carbohydrates as we grow old. We need large amount of proteins, good fat. I think madam was mentioning about omega-3 fatty acids. You need that. So do not cut off fat for elderly. Don't say, don't eat, don't eat. Don't get worried about a little bit of cholesterol high or a little bit of triglyceride. We go and put them on statins. That is not the concept now. The concept now is cut off carbohydrate, go in for a bit of protein, go in for more of fats, add vegetables, lots of vegetables and fruits to eat. So therefore, some things which you need to avoid is breads, pastry, drinks, banana. These things need to be avoided. So this is called as keto food pyramid, which is helping elderly a lot by cutting the carbohydrate. But there is a catch in elderly. You can plan the diet, whatever you want, but they have an added problem. They have poor dentition. How many of us really look into the oral cavity when we examine them? We don't. Yesterday, I had a patient. They said, Madam, her blood pressure is high, so they have sent us for you for look. I said, why? They said, no, her teeth are bad, so we are going in for extraction teeth. Okay, how many? No. They said that in a month's time, they'll take out about 12 to 14. So that means that, not even, a week's time, they're going to remove 12 to 14. So 4 to 5 teeth, they're going to remove per day. Now imagine this person whose teeth are removed and then she cannot chew, her gums are paining. Within a span of 3 months, she will go suddenly into malnutrition. And then you can never, ever revert this elderly back with nutrition. So dentition is a huge issue with them. They may not be able to chew. And then there's an over level of depression. They feel, I don't want to live. I don't want. So the first thing they do is they give up food. There's so much of drugging we do for diabetes, because they have a list, they have a package deal there as you grow old. Diabetes, hypertension, IHD, Parkinson's, thyroid, name it. And then they will have about 12 or 15 drugs. All those drugs kill the appetite. They have memory loss. They don't know they've eaten or not. They say, I have not eaten at all, or they've eaten. Then they don't eat at all. They said, no, I have eaten. Then they will have diarrhea because of what happens to their gut. They'll have diarrhea, and 25% no etiology why they don't want to eat. They just don't want to eat. So main thing that troubles an elderly with nutrition is depression, all GI, and also lurking malignancy. If there is a patient who says off food, umpteen times we find patient coming off food. Somewhere when we search, there is a malignancy. They become weak. You think, are an old person or he's weak, so I really don't have to see him. But then remember one thing, if the elderly says that I'm off food, that means there's something lurking. Watch for all these 3 issues. And I don't know how many of us, when they come in medicine OPD or whichever OPD, gynec also, because there are gynec patients there, we never check their weight. We never ever follow up their weight at all. So therefore, you have to do just like children, you have to do nutritional screening tool, which is very, very important. I keep in my OPD, the diet department is a regular part of our assessment. They have to assess nutrition. They have to tell me which is lacking. They have to calculate the nutrition, and they are a part of my comprehensive geriatric assessment. Okay, so you will pick up early malnutrition. What are the risk factors? And you have to give them therapy, and elderly people are likely to benefit from them. The commonly used tools in elderly are, we call it as minimal nutritional assessment, nutritional risk assessment, malnutrition universal screening tool, and we use this SGA regularly. It is called as subjective global assessment. So this is a very simple tool. The last one, please use it in all elderly. You will come to know what is the gap. So you have a simple 10 questions. So easy to do even in an OPD. Ask them any illness, what is the amount of food you eat, then do you eat fewer than 2 meals a day? So we score them. I'm not, because in 15 minutes I have to finish. So we give them points and we score. Each question we have points. So once we finish this questionnaire, we put them and we said, okay, low risk, moderate risk, high risk. So we put them into various risk category, and then we plan a diet for them. So you assess, you put them into not at risk and at risk. If it's not at risk, okay, regular meal in their house, continue. If they are at risk, diagnose and treat. So you see whether you can do a proper nutritional care plan, and then do not neglect elderly, because if you neglect nutrition, there's a lot of mortality and morbidity. How I will put a case for you will know. So they also have added burden of catabolic condition. So they will have disease related cachexia, what we call inflammation, and then loss of muscle mass for no reason at all. They lose complete muscle mass, and that we use the term called as frail. When we look at an elderly, please look at him and see, is he able to get up? You will see somebody coming, bending, one person holding and walking. That should warn you that he's having malnutrition or undernutrition, I need to buck up his nutrition. See his muscle mass, he's very thin. So we have a concept of frailty. He's slowing down. He has no muscle mass. His grip strength is very poor. So that is why the geriatrician, we use what is called as handheld dynamometer. But all simple tests you can do is ask the patient to hold your fingers tight. If he's able to grip well, good. Then if he is able to, ask him to hold his hands like that, get up from the chair without support. If he's able to do these two things, then his muscle mass is good. If not able to get up or not able to hold his grip, that means there's an issue with his muscle mass. Okay, then therefore you take history. Socially, sometimes they're very unhappy. Most often we have, nobody cares for me. My daughter-in-law doesn't cook food on time. I have nobody. Usually the complaint is on daughter-in-law. She doesn't cook. She's too busy, etc., etc. So in the way, the social situation is enormous, even in a country like ours. They fight with the children. They go away, stay on their own. They cannot cook. Then they'll make some, make-do thing. Just cook rice and eat all of it, whatever. So we also do in our OPD called anthropometric measurement. We look at body composition, and then body mass index we calculate, and most important, we assess their mental state very well. So we look at focused physical findings, and we calculate energy and protein needs just like you do in the pediatrics. And then we say which is the screening. We use validated tools. Then we put as diagnostic assessment. Okay, I have done all this now. Easy phenotype. If he is phenotype, weight loss, low body mass index, reduced muscle mass. Etiology, look at decreased food intake, or is it a disease burden? So we do a diagnostic assessment, then we come to a diagnosis. I need to have one phenotypic criterion with one etiology criterion. If I have to say my elderly is undernutrition, malnutrition, or needs a separate care plan for nutrition. So we do what is called as one phenotype. What is a phenotype? Weight loss, low body mass index, reduced muscle mass, etiology, reduced food intake for whatever reason, or there is a disease burden, and then we grade the severity. Okay, I'm going to put one case here. Okay, Mrs. Jayama, a 78-year-old lower middle class woman, brought in by her brother to the hospital. She has complaints of abdominal distension of 10 days, decreased urine output, she's drowsy. On examination, she has feeble pulse, blood pressure 90/60, tongue is dry, red, beefy, patient has no muscle mass. The brother is concerned that her sister will recover, but she has lost weight. Mrs. Jayama seems unconcerned about her weight loss and just repeats, she's old now and I'm not hungry. The brother explains that he takes care of his sister. So this is the situation now. Everything is recovered. She came with this, she improved, she went, but she is not eating. So when we explained the management strategy, so he said the son would take, the brother said his son would take care of it. The son did not volunteer to help, stating that she lived with her brother and he had nothing to do with it. So there is a fight between mother and son. She's gone to stay with the brother. Her husband died 5 years ago. Her eyes stare a bit as she tells you about this. She's too ill to speak. Now she has developed a bed sore and she appears neglected. So when we look at a patient like this, she's been discharged. In all probability, discharge summary, patient came and improved, but patient has not improved. She's gone home. After going home, she's become bedridden. So there are medical issues. But did we do nutritional assessment in her? Did we look that she's going to become malnourished? Did we check for body mass index? Did we do any lab tests? Did we look for dehydration? We didn't. We treated her clinically, sent her home, but we sent a patient who has become now bed-bound, bed-sore, and what is her quality of life? So patient is bedridden despite infection under control. So therefore, we have to see what is this Jayama's weight loss and in the last 1 month, what are the nutritional goals and what is to be expected. This workup is still not done in the hospital. I'm trying to sensitize all the departments. You have elderly, they come with fracture and they, please do let us know. We will help you. Rehabilitate them in terms of nutrition, rehabilitate them in terms of mobility, but I think it's not getting in there. So all sorts of problem will be there, chewing, poor oral hygiene, periodontal issues. So there's so many issues when we think of an elderly, and this is role of anorexia, cachexia. involuntary weight loss is something which normally patients will have, and you have got to pick that up. I lost weight voluntarily, but there are patients who will lose weight involuntarily. So you have to pick whether this is involuntary weight loss. That is very, very critical. So therefore, you look at, is the weight loss simple or is it cachexia, and make the difference. So nutritionists, you have to go one step higher and look into it. Once you do this, no change, no diagnosis, just nutritional support and look for improvement. This is the algorithm that you develop. Once you go deep into it, you develop. Now let's go back to Jayamma. So I taught you how you're going to do it. Is it involuntary weight loss? Is it cachexia? We have analyzed it. And then, okay, what does Jayamma need? She needs at least 5 grams per kg body weight, okay, of calorie. She needs hydration. She needs vitamin supplements. She needs oral iron. She needs calcium. She needs bed sore. And she needs family counseling above all. So maybe we calculate for Jayamma around 200 to 300 calories. Recommended protein for elderly is only 0.8. We don't give more than that. We don't give 1.5, 2 grams like children. Recommended protein is, and she needs, Jayamma needs this because she has. So for us elderly, we developed another pyramid. Healthy mind in a healthy body. If you do not sort out your mind, you'll never, they will never eat. And then there is a whole lot of cascading effect because of nutritional deficiency. So we put this as this, that is, first is nutritional balance. Enjoy, they should enjoy their eating. They should engage in activity. Above all, an elderly has to connect with the society. Conclusion, screening for malnutrition and dehydration is a must. Look for dehydration, calculate the amount of water that is needed. Look for candida, most of them will be on inhalers. Full mouth will be of candida. So please, all your nutritionists, open the mouth of an elderly and you will get whole lot of solutions, solvable problem for better nutrition. Calculate BMI always. Watch for unintentional weight loss in them. And then you look at, is it just regular or am I dealing with malnutrition? And then see that you correct the malnutrition in these elderly people. Thank you very, very, very much. Have I done in 15 minutes? Thank you.
Thank you very much, madam, for completing in 15 minutes and giving us a very good insight into the comprehensive geriatric care. Thank you very much, madam. And both of us, myself and I really feel privileged to chair the session along with our vice principal. And Dr. Suma is also my classmate in MBBS. So thank you very much for the organizers for giving us this opportunity. Thank you all.
I thank all the 3 speakers for sharing their valuable insights with us. I request the chairpersons to hand over a token of appreciation to our 3 speakers, Dr. Savita M.R., Dr. Vidya Tobbi, and Dr. Pratibha Pereira. I request Dr. Sumant, Associate Professor, Department of Community Medicine, Mysore Medical College, to hand over a token of gratitude to the chairpersons of the session, Dr. Suma M.N. and Dr. Suma K.B. Thank you, ma'am. Thank you, sir.
Further moving on to the next session, Research Simplified with Co-Guide REAP by Dr. G. Murli Mohan Reddy, co-founder and CEO of Co-Guide, the technical partner of NUTRICON 2022. Dr. G. Murli Mohan Reddy has done MD Community Medicine from PGI Chandigarh, Masters in Epidemiology from University of London, M.Med Family Medicine from CMC Vellore. He has conducted 100+ research methodology workshops across India and mentored 1,000+ biomedical research projects. He is involved in numerous national and international projects funded by Japanese Supplementary Budget, ICMR, and DFAT Australia. I welcome Dr. G. Murli Mohan Reddy, sir, on the stage to deliver the talk. Over to you, sir.
So thank you so much, ma'am. So can you connect the good morning, everybody. Thank you so much, all the NUTRICON organizing committee for providing us with this great opportunity. So Research Simplified by Co-Guide is the kind of theme of the session. So, and I got 15 minutes of time. So I'm considering it as a challenge if I'm able to complete a research project from sample size calculation, data entry, and data analysis within 15 minutes, then research is really simplified by Co-Guide. If no, then probably we are right. And thank you so much for the previous speaker, such profound messages delivering in such a simple manner. Hope I can continue that legacy. So India is shining. If we look at the research output for the last decade or so, from 2008 to 2018, India had surpassed Germany, and it has so it had emerged as the third highest producer in terms of the scientific publications. Not yet. And if we continue to project that particular data in 2030 around, it is likely to surpass even United States and enter into the global arena and stay in the global arena as the second highest producer of scientific publications. Massive success, but not everything is kind of shining there. If we dig deep into the story and see like what is happening. So we have taken research output from Scopus of one of a teaching medical institution in India, which had witnessed tremendous success. Leveraging on its research publications, it has entered into top 20 of NIRF ranking. If we look at the scientific publications growth of this particular university, in the year 2017, it was somewhere around 324 Scopus Index publications. But by the year 2020, it has reached 2,547, a massive 800% growth. How was that possible? It was a kind of tremendous case study. Okay, this was the story behind the screens. We looked into the platforms in which this particular university had published. There were 5 journals. Out of that one journal, if you see, in 2019, almost 1,000 articles have been published from this university in a single journal. Do you feel something fishy there? One journal publishing 1,000 articles from a single university in a single year, on an average 25 to 40 articles per issue, 480 publications in a year, right? If the journal is going in monthly frequency, but 1,000 articles, right, from a single institution, right? So what happened after that was this issue did not go unnoticed. If you see, all those 5 journals in which that particular university had published are out of Scopus Index now, right? Not only those 5 journals, there are many more in the line. Scopus is on a DVDing drive, right? Almost for the last decade, if you see, every year more than 500 journals are being thrown out of the Scopus Index because of questionable or non-credible practices, right? So the bottom line is, this particular institution, after witnessing a massive growth, so short period of time, has witnessed a massive decline after that, 400% decline in the subsequent year. And this is not only happening with a particular institution, happening with many institutions across the country and many individual researchers also, right? So they have resorted to a particular sort of practices, and then after that, ecosystem is changing so rapidly, again, there is a massive decline. Let us get into the personal level of it, right? If I ask all of you, how do you rate your intention to do research? Maybe 90% of us will say, okay, probably I'll say 9 out of 10 or 10 out of 10. But when I ask you the other question, how do you rate your efficiency of execution of your research and the intention to execution gap, right? I want to do so much, but I am able to do only so much. That is massive, right? Especially in Indian setting. And most of the times researchers or even the institutions will resort to something called self-loathing, right? So self-criticism that, okay, I am trying my level best, or I am not so good, I am becoming lazy, I am not doing research. But fact is not so simple, doctors, right? India is a unique setting. If we observe carefully, as compared to the global institutions, India is setting with high clinical burden, no dedicated time for research in many of our academic institutions. Funding availability and distribution of the funding is a big issue, and limited resources in terms of access to the databases and all other issues, and leveraging penalty. Many of our institutions, they won't reward performance in terms of the research publications, but if you don't publish, you will be penalized. So we are sort of, while doing research, navigating through an unknown territory all alone. So this unique situation of executing research in such a resource constrained environment needs a unique solution. So we have embarked on that journey to create that unique solution. But over a period of time, we have understood rest of the globe, sparing 1 or 2 settings, is not different from India. Entire globe is suffering from similar kind of issues. And what they need is research process optimization, both at the individual level and at the organizational level. So we have embarked on this journey to creating these research optimization solutions at all levels: research execution, research management, and the research leadership level. So I'll be demonstrating the first application called REAP, Research Enablement and Productivity Platform, to execute a simple research project and show you how it can make your research process so optimized. So let me straight away take you to the demo. So this is a web application. So a person has to sign in using their login credentials. You will enter this project dashboard. Let us imagine I have a simple research project where my research question is whether oxidative stress is higher among obese PCOS women as compared to women without obesity, right? PCOS women without obesity. This is my research question. Let us see how can I execute this project using CoGuide REAP platform. So I am going and I'm searching the literature. I am finding this reference article where they have compared oxidative stress between obese and non-obese PCOS women. So I am now going to the CoGuide platform. I am creating my project. There is a fantastic wizard called Title Wizard where you can write the title of a research project in a internationally standardized PCOS format. So let me use that. It is asking how many study groups you have. I have 2 groups. Do you have any intervention? I don't have any intervention. It is asking me what is your study population. Your study population is PCOS women with obesity. What is the outcome is oxidative stress. PCOS women without obesity is my control group. I don't know what is the study design. For the time being, I'll leave it as observational study. Later on, we'll see how the system can get. So timeline, I'm not really keen. So it is giving a title in a standardized format, right? So it is allowing you to think one step at a time about your research project, feeding in simple details, and it is giving you the title. So I can just add the title. For the want of time, I will not demonstrate the objective. It will work in the same way, right? So to probably study the or to compare the oxidative stress between. So I'm creating my project. So after creating the project, I can go and execute my sample size calculation. I can collect the data using the application. For example, how can I execute sample size calculation? So click sample size calculation button here. You confirm. Then it will ask very simple questions in an algorithmic manner, right? It is asking, are you doing diagnostic accuracy of a test here? No, I'm not doing diagnostic accuracy test, right? So I click no. Then, are you doing any intervention as a part of the study? No, I'm not doing any intervention. How many study groups you have? I have 2 study groups. Has the outcome already occurred? Yes, oxidative stress is already there. So I'm going to measure already the existing outcome parameters. So oxidative stress we are measuring by MDA levels or SOD. It is a number, right? So it is a numeric value. For example, if there is a very early researcher who does not even understand what is numeric or what is proportion, right? So there is a video embedded here everywhere, right? So if you just click that video, you can start watching that video. They're all very small 2 to 3 minute videos. By quickly watching it, you can quickly understand what is numeric, what is proportion, right? So learning is happening on the go through these embedded videos. So here it is a numeric outcome. I'll click numeric outcome. Then it is asking me to feed in certain details based on my reference article, right? So what is the outcome? I'm taking MDA as my outcome. So PCOS with obesity. Name of the comparator group, normal PCOS without obesity. I'm not, yeah. So my MDA value, mean and standard deviation from the reference article. So I'm going to the reference article. I'm reading the result section. I'm taking the MDA value from here, right? Yeah, 0.29 and 0.27, right? So in non-obese and obese. So 0.229 and the standard deviation is 0.05, 0.273 and 0.01 was the standard deviation. Then power of study, I can keep it at 80%, 90%. Again, if you don't know what is power of study, there is an embedded video underneath. You can watch the video and you can learn. Now I'm copying the title of the reference article in a proper format. So I'm going to PubMed. I'm taking this site functionality. I'm getting the article. So I'm taking the reference. So I'm taking the first author name and putting it here. I've just fed in the relevant details. All it took is just 3 to 5 minutes time. So then you click submit. You get a fantastic output, right? So which is giving you the study design and also giving you a detailed sample size calculation along with the formula and sample size required in each of your study groups, and also a brief description of what statistical tests you are going to do, along with the references for the formula from where you have taken, and also the reference article. Right. Yeah. So your sample size calculation, 3 things: study design, sample size calculation, and statistical methods, along with the required references. No other software will give you such a comprehensive output. You can directly copy paste into your material method section, and then you can start executing your research study. Another fantastic feature along with the learning is real-time support, which is available to you through this chat support function. So you can click this chat support function and you can just start communicating with our team. Achha, you can say, okay, I'm a registered user. Then immediately the chat functionality will start communicating with you. So then it will ask, okay, what support you require? Okay, I'm calculating sample size. I have some doubt. Okay, I'm clicking sample size calculation, right? So then it will ask like, what is the exact issue where you are encountering the difficulty, right? So you can keep on communicating. The algorithm and also a 3-level support system, which is there in the back of it. So they will come into your rescue and they will sit with you. They'll understand your requirement and they'll try to navigate through the bottleneck which you are having, right? So the bottom line is you can be self-reliant with respect to your sample size calculation using this application. You need not run around for any technical help. Once your protocol is submitted to the ethical committee and your protocol is getting approved, after that you enter into a data collection phase, right? Traditionally, what we do is usually we take a physical proforma, we collect all the data and then we keep it. Whenever a department is having a review after 6 months, you run around and you start entering into Excel sheet. Some data is clean, some data unclean. Sometimes the same pro forma which you have collected, you may not get some of them, right? You have left it in a room, in last place, right? Hospital ward. The problem is we lose the data and then we accumulate all the work, and we usually take a lot of burden in short periods of time, again impacting the quality, right? And you don't enjoy the journey at all. Let us see what is different with re-platform, right? For example, I'm taking just these simple parameters in my study. I'm just taking age, hypertension, and some hormones, and 2 parameters, MDA and SOD, to measure the oxidative stress. I want to compare between obese and non-obese PCOS women, right? So I go to re-platform. There is a function called data entry. You click data entry. You will be taken to a dashboard where there is already a list of predefined variables available. You can pick and drop all the relevant variables for your study, and you can create an electronic data entry template. So these are the variables list. I'm going to demographic variables. I'm picking age. So I'm going to comorbidities. I'm picking hypertension. So I'm going to anthropometric parameters. I'm picking my BMI. I'm going to laboratory parameters. I can even search. So I can go to hormonal profile, take total testosterone and follicle stimulating hormone, and I can go to oxidative stress related parameters. I can take MDA and SOD. So now I have set up my electronic data entry template. All I need to do is just click submit. My data entry template is ready to take my data. Right now, as your first participant is getting recruited and you are collecting the data, you can straight away take out your mobile and enter the data then and there itself, right? So for example, I'm entering age is 27, hypertension, yes, BMI is 23.47, total testosterone I'm entering 4.8, 6.7, 0.12 and 80.21. So I'm entering my first participant's data and click add data. Your data is saved. You can view data in a nice spreadsheet format. You can even download it. For example, after a week, you are completing your second participant's recruitment. You can go back to your add data function. This pro forma will there. You need not redo again and again. All you need to do is sign in, click data enter, and then start entering my second patient's data or participant's data, right? So for example, 25, my hypertension is no, BMI 26.99, testosterone level I am entering, okay, 5.7, 4.92, 0.26, and then 84.3, whatever values I'm entering, right? So I'm getting my second patient's data nicely, and I can download it using the download functionality here in an Excel format anytime. See, a nice clean Excel sheet is being prepared. And most important functionality in the REAP application is the analysis, right? This particular data entry template is linked with a real-time data analysis dashboard. So you click analyze. All the descriptive analysis is a single click away, right? You need not go to a software, run the analysis, take it out, spend a lot of time in cleaning the tables, right? So I have seen a friend just breaking the screen because he could not put one table and graph in a position, right? So he was adjusting hundreds of times, it was going again haywire, right? And the fantastic thing is it is a real-time update analysis. So as you go back and start entering your third patient's data, the analysis gets updated automatically, right? And also you can upload the data. So I'll just add one more patient's data just to demonstrate how it works. The moment I'm adding my third patient's data, my third patient's data is ready. And the moment I click analyze, my entire three patients data is analyzed. Now you can see my three participants data analyzed. So it becomes very easy. Whenever your department is conducting a review, just go log in, take a printout and go and present it in your department. You need not run around anytime, right? So you are being very organized, redistributing your entire activity over a period of time. As you are collecting data, your analysis is also getting ready. And you can also upload the data. If you are collecting an Excel sheet outside, so I can upload the data. So I have a Excel sheet already. So I can just click upload. The entire data is uploaded of around 100 patients data I have already entered. It is uploaded. Now I can run the analysis. I can configure the analysis. Now what do I want to do? I want to compare MDA and SOD values between obese and non-obese PCOS women. In traditional scenario, you need to know that you have to do a T-test or a Mann-Whitney U-test, and then you go and run the analysis, right? But here in this application, you need to know as a clinician or a nutrition expert what comparison I want clinically or from nutrition point of view, right? So I'm going to analysis dashboard. There's a configure analysis function, right? Using this, first I want to get obesity, right? So using BMI values. So I can configure grouping, add numerical groups. I'll say take BMI and get me obesity. So label as normal. Minimum value is 0. I will take 24.99 as a cutoff. Then I'll take obesity, where 25.00 to the highest value. I'm just configuring my group obesity, right? It was not there in the beginning. The moment I click done, my new variable is added, right? So basing on BMI, I could able to configure obesity. See, in the end, you can see obesity. Now, the moment you run the analysis, it is automatically added to the dashboard, 50 obese and 50 non-obese PCOS women, right? Now I want to do a comparison, right? Configure analysis, go and add configuration. Here again, numeric, there is a bit of jargon. Wherever there is a jargon, again, there is a video, right? So now I want to compare, let us say, MDA values. I want to put my obesity in the columns, and I want to get a comparative bar chart. Or I can even say combined block box plot, and I will say, okay, comparison of MDA values with obesity. I click save. I click generate report. Initially, the analysis was not there, the comparison. Now you can see MDA values are compared between normal and obese pregnant women, mean plus or minus standard deviation, along with the p-value, along with the statistical test, right? You never knew that you need to do a t-test here, right? But you knew I want to compare MDA between obese, non-obese. So it is automatically picking up the test and also giving certain instructions whether you need to pick a t-test or a Mann-Whitney U-test. There are normality plots automatically generated here. You can see them. And also in the bottom of the table, it is mentioning both the shape of normal distribution curve, frequency distribution curve, and also the Shapiro-Wilk test p-values and other normality assessment is showing it is normally distributed. So you go and pick a parametric test, right? Both the tables are readily available to you, parametric and non-parametric, Mann-Whitney U-test, and you can pick the right test depending on the instructions given by the software, right? So the entire process of picking up the statistical test is automated in the background. Can I conduct a chi-square test? Yes, I am taking hypertension as a variable. And I am taking obesity as a comparison parameter. Now I'm selecting something called stacked bar chart. I'm simply, for the want of time, putting hypertension. See, you get a table with a chi-square value and p-value, along with the stacked bar chart clearly representing what is the percentage of hypertension in obese and non-obese PCOS women, right? I can get the correlations like that. For example, I want to see take BMI, or let us say I want to take superoxide dismutase, and I want to take BMI. And I can select a scatter plot. So you get a nice scatter plot with correlation coefficient value explaining there is a negative correlation between BMI and SOD values, right? In this way, you can set up the entire analysis dashboard in the very beginning of your data collection period. After that, all you need to do is keep on entering the data. Your results are getting automatically generated every time you are entering a new participant's data, right? So you need not run around for any statistical or other help multiple times, right? So another important feature of the application is there is a functionality called learning. If you click the learning module, there's a fantastic video learning modules organized in a very structured way. See, the difference between a regular learning and this learning is the size of the video is just 3 to 5 minutes, right? So the size of your TikTok or short YouTube videos, your generation is sort of habituated to that kind of learning probably, right? So we wanted to just give the information in a 3 to 5 minute videos. Very few videos will go beyond 10 to 11 minutes, right? The entire basics of research module is 65 minutes, right? Whenever you are free, you are traveling, right? You can just open up, watch one video and learn one important concept. So we are promoting and encouraging a very strong research learning while you are executing the research. One time, if you are learning on one project you are executing, after that, you are a self-reliant researcher. You are a learned researcher already, right? We have a lot of events ongoing. So further intense training of research-related skills, all of you can just go and register for any of these sessions and attend. Most of these sessions are online and hands-on. Another important feature to avoid predatory journals, people are nowadays, it is a very important issue it has become. We see so many faculty members coming to us. We have published in a particular journal, now NMC or UGC is not accepting it for my promotion, right? So we have a journal search feature. It is a database of close to 30,000 journals. You can go there and you can search any journal, right? So for example, if you want to search with nutrition, right? So you get all the journals with the nutrition word in their title, along with very important details which can aid you in the decision making, right? What indexes are this particular journal indexed in currently, right? It is verified every fortnightly. Second important thing, whether there is any publication charges, what is the amount of time taken from publication to acceptance. All these details are very, very important for you people to take the decision, right? And you can also filter them out using these parameters, for example, indexing, or you can choose a particular impact factor range, right? Depending on the quality of your research paper, right? And then you can filter it out so that you can get further narrow results, right? So Indian Journal of Nutrition, what is the impact factor, what are the indexes, and what is the time taken and other parameters, right? So that means it's an end-to-end support in terms of your research project execution and guidance with a publication. And most importantly, doctors, I would like to show you this is our second version. What I have demonstrated you is the first version, right? Our second version of the application is in the phase of testing now. In another 2 to 3 weeks, we are going to make it live. It comes with the fantastic functionalities of document editing. So as you are writing your research project, step by step. For example, you're writing title using title wizard, automatically a document starts getting generated, right? In the sidelines. That means you need not go back to your Word document. You need not email your Word document, right? And another important functionality we are going to get you here is the citation management, right? While writing, you need to cite the existing work using Vancouver or Harvard, other forms of citations. So this particular application will come with an inbuilt feature of Vancouver format of citations also, and also an inbuilt plagiarism check. All this is going to take another 3 to 6 months, but it is going to be a complete application. You enter it with your research idea, you get out of the application with a ready-made, kind of ready to submit manuscript in your hand or ready to submit thesis in your hand. And we are going to build a collaboration mentorship module over it. You can invite your guide, your mentors, or your co-researchers to interact over the document, and all the process you can execute over the platform itself. And also a minute for the leaders, right? For the senior faculty members and the administrators who are here. We have another application called RMS, Research Management System. We go and sit with the administrators of many organizations, right? When I ask them, what is happening to your research, sir or madam, they say they have a very clear idea about their research output. So many publications we have done. This is our H index, this is our I-10 index. But when I ask what is happening to your research process, they are at loss. They call 10 different people from 10 different departments. What is happening in your department, right? Even the review meetings which happen to streamline the research process in the organizations will go completely haywire, blame game, right? Not objective, not data oriented. So we have built this RMS application where you can create a centralized. This is a process dashboard where once the project is submitted to your scientific committee or ethical committee, it will go into a denominator. From there, a tracking process starts. So at any point of time, the administrator can sit with their system, log in at a single click. They get access to a very comprehensive project management dashboard, right? So they can understand each department, what is happening with the project initiation, what is happening with the project execution, how many projects are being completed, how many projects are being submitted as a manuscript, and how many manuscripts are coming out of each department, right? So it makes things really easy for you. You can have control over the pulse of your research process. We are shifting the focus from output to the process. Take care of the process, output will happen automatically, right? Many people ask us, can you hear me? Yes, okay. So many people have concerns regarding data safety, security, and usage policy. So this is our comprehensive data safety mechanism which we have in place. All the data which you are entering into this REAP or RMS platform is immediately encrypted, right? With the latest standard encryption mechanisms. And backend team cannot see your data in the form in which you are entering. It is encrypted the second you are entering it. And also the backend and the database is maintained in Google Cloud Platform and also Amazon Web Server. They come with their own layers of data safety and security issues. And also mainly the team, right? We have a very meticulous standard operating protocol of training all our team members with respect to all the aspects related to data. There is a very stringent incident response system. The moment we see there is some incident concerning the data and safety and security, we immediately respond to it, and then we immediately inform the client, and then we take necessary measures. So far, nothing has happened like that, but we have a mechanism in place. It is like a disaster mitigation measure, right? Already advanced, it is in place. And most importantly, we are trying to get a certification for ICH compliance, right? International Committee for Harmonization of Clinical Trials. There are certain standard guidelines with related to data safety, security, and access. We are trying to get that certification, right? But as of now, all the security aspects are taken care of nicely. And in terms of the data usage policy, the person who is entering the data into the system is considered as the owner of that particular data. That data will not be used for any other purpose without your explicit consent. Very clear about it. So already we are being trusted by many people. We are already kind of contributing to a lot of real world evidence. There's a global snakebite database we are maintaining. There is a network called Avoidable Death Network. So in collaboration with them, we are maintaining this database. Many government and private institutions are contributing data to this global snakebite database. Knee arthroplasty, team of orthopedicians are contributing to this database. Antifungal stewardship, another company, kind of a pharma company is kind of driving few hospitals to manage this antifungal database, right? Their culture and sensitivity patterns. Oncology, we are maintaining a database. Infertility, subfertility is another domain where we are working very actively. And also, I welcome you all to this global research community, doctors. Beginner researchers or very advanced expert researchers, all of you are welcome to be part of this community. We are undertaking very vigorous evidence synthesis and guideline development activity. In your field of expertise, if you come out with the right scenario, we have a mechanism, we have a team and institutional mechanisms to conduct evidence synthesis on that particular subject in terms of writing a systematic review meta-analysis or a guideline document. Real world evidence, again, you are welcome to kind of start any real world evidence project in your subject specialty. Any of you can lead that particular project, right? You need to give us an idea and we'll make it happen. Research skill development is one of our commitment. We want to build an army of skilled resources. So please be part of our system. And we keep on coming at you with various options to skill up yourself in terms of the research skills. And of course, research mentoring, depending on your level of skill set, you can either receive mentorship or you can deliver mentorship to your junior level researchers. And everything can be happening in a very transparent and very technology driven ecosystem where people with a high end clinical skills can start mentoring their subsequent generations, right? And the baton can be passed on. In that way, we are generating we are creating a massive global research ecosystem. So leveraging on all these things, we are transforming research execution, we are transforming research management, and we are transforming the way leadership is looking at research. This is our vision. By 2027, we want to create a massive global research ecosystem with 1 million plus researchers spreading across 20 countries, having at least 100 plus elite institutions onboarded, catering to the evidence needs of all the stakeholders, government, industry, academia, funding agencies, everybody. So please welcome. You are you can be part of this ecosystem and you can transform the way research is being done and you can lead the way. What we want to do is create a new world order in scientific research, keeping India as the epicenter. Please welcome on board. We have our stall, so please come and interact with us and let us start traveling together. Thank you so much.
Simplified, sir. Thank you very much, sir. I request Dr. Sanjay Pandey, Professor, AIMS, Patna, to hand over the token of gratitude to Dr. G. Murali Mohan Reddy. Thank you, sir. Next, we shall be commencing the inaugural ceremony shortly. I request all the delegates to be placed wherever seated. Thank you. Shri Shivaratri Deshikendra Mahaswamiji. On behalf of the organizing committee, I, Dr. Rashmi S.,
And I, Dr. Kavya Upadhyay,
extend a very warm welcome to all the dignitaries, guests, speakers, delegates, and media personnel to the inaugural ceremony of the National Conference on Nutrition, My NutriCon 2022, which is organized by the Department of Community Medicine in collaboration with Department of Studies in Food Science and Nutrition, University of Mysuru, and Department of Nutrition and Dietetics, School of Life Sciences, JSS Academy of Higher Education and Research, Mysuru.
we have with us on the dais our esteemed chief guest, Dr. H. Basavanagoudappa, Dr. Surinder Singh, Honorable Vice Chancellor, JSS Academy of Higher Education and Research, Organizing Chairpersons, Dr. Sunil Kumar D. and Dr. Komala M. Organizing Secretary, Dr. Praveen Kulkarni, and Joint Organizing Secretary, Dr. Vanita Reddy.
I now call upon Ms. Deepta Raghuram to invoke the blessings of the Almighty for the day's program.
Mahaganapatim manasa smarami Mahaganapatim manasa smarami Mahaganapatim manasa smarami Vasishta Vamadeva Divandita Mahaganapatim Mahadevasutam Guruguha Vinutam Mahadevasutam Guruguha Vinutam Manakoti Prakasham Shantam Mahakavyanatakaadipriyam Mahakavyanatakaadipriyam Mushikavahanamodakapriyam Mahaganapatim manasa smarami Mahaganapatim manasa smarami Vasishta Vamadeva Divandita Mahaganapatim
Thank you, Ms. Deepta.
I now call upon the organizing chairperson, Dr. Sunil Kumar D., Professor and Head, Department of Community Medicine, JSS Medical College, to welcome the dignitaries and the delegates to the occasion.
Seeking the blessings of His Holiness Mahaswamiji. A very good afternoon to all the dignitaries on the dais and off the dais. We, the Department of Community Medicine, JSS Medical College, in collaboration with Department of Studies in Food Science and Nutrition, University of Mysore, and Department of Nutrition and Dietetics, School of Life Sciences, JSS Academy of Higher Education and Research, greet you all to this National Conference of My NutriCon 2022 with the theme of Public Health Aspects of Nutrition Towards Sustainable Developmental Goals. I welcome our Vice Chancellor, Dr. Surinder Singh, who is also presiding over today's program and always supporting and encouraging us. I welcome you, sir. I welcome our guest of honor, Dr. H. Basavanagoudappa, Principal of JSS Medical College, who encouraged and supported us in organizing this national conference. I welcome you, sir. I welcome Dr. Komala M., Professor and Chairperson, Food Science and Nutrition, University of Mysore. I welcome Dr. Vanitha Reddy, P. Coordinator for the Department of Nutrition and Dietetics, JSS Aher, Mysore. I welcome Dr. Pavin Kulkarni, Organizing Secretary, who has worked hard for this organizing in this national conference. I welcome Dr. Suma MN, Vice Principal, to this program, who always supports us wholeheartedly. I welcome you, madam. Suma, madam. I welcome Shri Satish Chandra SR, Administrative Officer, who will be there always for our support and encouragement. I welcome you, sir. I welcome all our eminent speakers for today's national conference, all our judges and chairpersons. I welcome our university officers and heads of the departments and other all teaching and non-teaching faculty to this conference. I welcome my team, my colleagues, PhD scholars, postgraduates and undergraduate students to this national conference. Last but not least, I welcome all the delegates from across the country to this national conference. I also extend my welcome to press and media friends to this national conference. I hope this conference will be productive and you will learn about how the nutritional aspects will help in attaining the sustainable developmental goals. Thank you very much.
Thank you, sir. We also extend a warm welcome to you, sir.
I now request all the dignitaries on the dais to inaugurate the event by lighting the lamp.
Shubham Kurudham Kalyanam Arogyam Dhanasampada Chaturbuddhi Vinashaya Deepajyotir Namostute Deepajyotir Namostute Deepajyotir Parabrahma Deepajyotir Janardana Deepajyotir Parabrahma Deepajyotir Janardana Deepo Hartu Me Papam Sandhyadeepa Namostute O Deepa Brahma Rupasvam Jyotisham Prabhuravyayah O Deepa Brahma Rupasvam Jyotisham Prabhuravyayah Arogyam Dehi Putrasya Matim Swachham Ime Sada Raverastam Samarabhya
Thank you, respected dignitaries. I now request Dr. Surinder Singh, Honorable Vice Chancellor of JSS Academy of Higher Education and Research, to release the e-souvenir commemorating the event My NUTRICON 2022. I request the other dignitaries to also join him. Thank you, sir.
I now request our chief guest, Dr. Baswan Gaudappa sir, to address the gathering.
Good afternoon to everybody. Respected Vice Chancellor Dr. Surinder Singh ji, other dignitaries on the dais, off the dais, and respected resource persons for this wonderful NUTRICON conference that is going on, and dear participating delegates and fellow students. When Dr. Sunil Kumar and his team from Department of Community Medicine came and approached us that they want to organize the national event, My NUTRICON 2022, we were very happy because this is what is required for the important component of health preservation as well as disease management has to happen through the nutritional therapy. As we have understood so far, the diet and the nutritional aspects play a very, very important role for wellness as well as taking care of illness. The other day when we addressed the press meet, the press people asked us, can you tell us the important advancement that has taken place through your institute in the last 1 year in this area? And Praveen and Sunil were a little evasive because they didn't want to reveal the secret of research that has happened, and we didn't have our diet and nutrition department head there. So we told them, come and witness the conference. You will get to know. Though the first session started with a very innovative topic of nutrition through the life course approach, started with pediatrician from Mysore Medical College and ended with geriatrician from JSS Medical College. They took the session through to give you the entire knowledge of how the nutritional demands, requirements, and the implications of nutrition related aspects impact our health. Starting from that, we are going to end up with what has been happening in the recently in the research in the area of nutrition on the impact of health. And there are technical sessions, several scientific sessions and panel discussions. I don't want to interfere with your time availability for academic program of this kind. It is wonderfully designed and very good resource persons have been selected. I am thankful to Dr. Komala from Professor and Chairperson, the Department of Food Science from Mysore University, and also the Organizing Secretary, Dr. Praveen Kulkarni, has done a wonderful job in collaborating, coordinating, and executing this wonderful academic program. And Sunil Kumar, who has taken over as a head of the department recently, has been doing good job in trying to take the staff and the students together to academic deliberations, executing the academic delivery, as well as convening these kind of activities. I'm thankful to all those resource persons who have responded to our request. And unfortunately, a big international nutrition conference is happening in Japan. So many of the leaders are there in that conference. Otherwise, this would have been much more wonderful. But our Vice Chancellor was astonished to see so many participants in NUTRICON. And I thank all those who have registered as delegates and participating. I wish this conference a grand success, and all the intended deliberations, let it happen very appropriately. I am sure all the participant delegates will get what they desired to get and what they came with anticipation. And let it happen in a proper way. Let them get more than what they came for with anticipation. I wish this program a very grand success.
Thank you, sir. I now call upon Dr. Surinder Singh, Honorable Vice Chancellor, JSS Academy of Higher Education and Research, to render the presidential address.
A very pleasant good afternoon to all of you. At the outset, I submit my humble and respectful pranams to the lotus feet of His Holiness Swamiji, the Honorable Chancellor of JSS Academy of Education and Research. My warm greetings to the chief guest for today's program, Dr. H. Basanagurappa, the principal of JSS Medical College, who is the chief guest for today's program and whom you just heard about his remarks about the today's program over there. All the dignitaries on the dais, off the dais, and all the participants who have gathered over here from across the length and the breadth of the country, and the faculty who are there for this program, my very warm greetings to all of you. At the outset, I would like to congratulate the Department of Community Medicine, JSS Medical College, Department of Studies in Food and Science Nutrition, University of Mysore, and Department of Nutrition and Dietetics, School of Life Sciences, JSS Academy of Education and Research, for jointly organizing this national conference on nutrition, that is My NUTRICON-2022. As we are all aware that our country contributes very significantly to the global burden of malnutrition. At one point, there are a large number of children who are suffering from consequences of various grades of undernutrition. And on the other hand, there is a progressive increase in the burden of overweight and obesity across all stages of life. Micronutrient deficiencies or hidden hunger is another form of underexplored and inadequately addressed domain of nutrition health issues, which needs a special attention. Nutrition health problems are multifactorial and multidimensional in nature. There is a diversity in relation to the magnitude of these problems across the age groups, genders, localities, ethnicities, and traditions. There is a need for multi-pronged approach in addressing these issues, and nutritional interventions tailored to the felt needs of the people, which are socially acceptable, economically feasible, and potentially sustainable, should be implemented. And I think these issues would be deliberated in this conference. UNDP's goals are the international commitments to achieve health and well-being of people across the globe. Goal 2, which deals with hunger, calls for large-scale nutritional intervention amongst the global communities to ensure food safety and security amongst the people in all sections of society without any kind of discrimination. The achievement of Goal 2 directly contributes to the achievements of target under Goal 3, which deals with good health and well-being. Health and well-being are largely influenced by nutritional status, eating practices, food preferences, and consumption patterns of individuals and communities. Thus, the health and nutrition are conjoined and inseparable entities. JSS Medical College and JSS HER are highly committed to contribute towards United Nations Sustainable Development Goals. The institution strives to engage multiple stakeholders at various levels through collaborative partnership and networking to advocate for attainment of various SDGs. The present conference is one such initiative by our institution, as this provides a sustainable and a suitable platform for the experts, scientists, practitioners, research, and scholars to share their knowledge, skills, and experiences on a long-term basis on various aspects of public health nutrition, with special emphasis on SDGs. As the outcome of this conference, I urge the resource person and the scientists and the participants who are here to come out with a resolution which outlines the set of nutritional interventions that can be adapted at individual, family, community levels to enhance the nutritional status of people at various stages of life. We can also pass on the set of recommendations to the policymakers and government on the priority areas in nutrition health problems, cost-effective solutions for these problems, and ways and means to achieve food safety and security across the communities. This resolution can be circulated at national and international platforms for further deliberations and discussions. I once again congratulate the organizers, all three of them, for conceptualizing the theme of this conference and designing the scientific sessions. And as just Dr. Basanagurappa just elaborated, that we had very nicely deliberated first session which was there. And these sessions, they will support the theme of this conference. I end this speech with the adage that let food be our medicine and not let medicine become our food. I wish this conference a great success and wish you all the best for all the participants who have come across the length and the breadth of the country. Thank you.
Thank you, sir. We have now reached the end of inaugural ceremony. I request the organizing secretary, Dr. Praveen Kulkarni, to propose the vote of thanks.
Very good afternoon to all. Seeking the blessings of His Holiness Mahaswamiji, I take the proud privilege in proposing the vote of thanks of the inaugural ceremony of National Conference on Nutrition, My NUTRICON 2022. I would like to extend my thanks to Dr. Surinder Singh, Honorable Vice Chancellor, JSS Academy of Higher Education and Research. Sir is a man of actions and outcomes with great leadership and administrative skills. Thank you very much, sir, for presiding over this ceremony and sharing words of wisdom with us. Thank you very much, sir. I'd like to express our sincere gratitude to our beloved principal, Dr. H. Baswan Gaudappa, sir, who is a constant source of inspiration to all of us. Without his guidance, support, and cooperation, this conference could not have been a reality. Thank you very much, sir. I would like to express our gratitude to Dr. Komala M., Professor and Chair, Food Science and Nutrition, University of Mysore, for being collaborated with us and providing timely and valuable guidance and inputs in designing and implementing the proceedings of this conference. Thank you very much, ma'am. I thank Dr. Sunil Kumar D., Organizing Chairman, who has been a backbone of this conference and worked tirelessly in conceptualizing and organizing this conference. Thank you, sir. I thank Dr. Vanita Reddy, Joint Organizing Secretary, for her support and cooperation. Thank you, ma'am. I thank Dr. Sumay Amman, Vice Principal, JSS Medical College, for being persistent supporter, mentor, and guiding force for all our activities at every step. Thank you very much, ma'am. I thank Shri Satish Chandra SR, Administrative Officer, JSS Medical College, Mysuru, who is an administrative pillar of this conference. Thank you very much, sir, for your valuable support and guidance. I thank all the resource persons, chairpersons, judges of scientific presentations who have come from various parts of the country on our invitation to share their valuable knowledge and experiences. I thank authorities of JSS Academy of Higher Education and Research and University of Mysore for providing their unconditional support towards organizing this conference. I thank university officers, head of the departments, teaching and non-teaching faculty of JSS Medical College and JSS AHER for extending their support towards organizing this conference. I thank all my colleagues in organizing team, PhD scholars, postgraduates, undergraduates, and administrative staff of our department for their hard work and commitment in making this conference a reality. I thank our technical partners, CoGuide, media partner, Pratinidhi Patrike, web technology partners, Code Flurry Technologies, print partner, The Rangu, and other sponsors for their financial and technical support. I thank IT, electric, housekeeping, and security staff of JSS Medical College and JSS AHER. I thank press and media for providing wider coverage of this conference. Last but not the least, I thank our delegates who have come from various parts of the country to gain the knowledge and build networking. I hope the 2 days scientific deliberations will help you to shape your career as a successful professionals to contribute towards public health aspects of nutrition to achieve sustainable development goals. Thank you, one and all.
Thank you, sir. This concludes the inaugural ceremony. Thank you, dignitaries, for gracing the occasion. We shall now move on to the next session.
Moving on, the next session is Keynote Address on Public Health Aspects of Nutrition Towards Sustainable Development Goals by Dr. Raghavendra P. Dr. Raghavendra is currently working as Medical Scientist C at ICMR NIN Hyderabad. He did his MBBS from PES Medical College, Kuppam, and completed his MD in Community Medicine from Siddhartha Medical College, Vijayawada. He has worked in the capacities of a senior resident and assistant professor in Vijayawada before moving to the Kingdom of Saudi Arabia to serve as a public health specialist. Since 2018, he has been working with the Division of Public Health Nutrition and ICMR NIN. He was involved in various scientific projects that included the establishment of nutritional surveillance system, the development of evidence-based food models for children, outbreak investigations in Muzaffarpur, the effectiveness of front-of-pack nutrition labels, the development of intervention models for prevention of infantile beriberi, and so on. He has published various research papers and has contributed 2 chapters to the recently released Nutritional Requirement for Indians 2020. He is a member of IPHA, IAPSM, and Nutrition Society of India, and has rendered service as a member of the Electronic Working Group of the Codex Committee India to work on front-of-pack nutrition labeling, FSSAI's Network of Scientific Cooperation for Food Safety and Applied Nutrition, NCDC's Committee working on mitigation of nutritional issues of climate change, and ICMR NIN Institutional Ethics Committee. I welcome Dr. Raghavendra P. to deliver the keynote address. Over to you, sir.
Hope I'm audible. Thank you, Dr. Kavya, for a kind introduction. My respects to the organizing committee, the JSS community, and all the delegates present here. A very warm greetings on this winter noon, and thank you so much for having me here today. As our principal sir has said, it was actually my HOD, Dr. Lakshmaya, the senior most public health epidemiologist of the country, to be here. He had to be here, but because he was attending the ICN International Conference of Nutrition at Tokyo, I'm trying to substitute him. Any success in bridging the gap will be an achievement for me. So yesterday's workshop, we had quite a few of the delegates present here, where we had a lively session with a very enthusiastic bunch. So for those who are not present there, I am Dr. Raghavendra, currently working as Scientist C at the ICMR National Institute of Nutrition, which is the premier nutrition research institute in the country. So coming to the conference today, there couldn't have been a better time to have this crucial conference with a very apt theme, that is the public health aspects of nutrition towards sustainable development goals, with just 8 years left for the achieving these goals. And what better time it to be to talk about hunger just before lunch. But on a serious note, the relevance of the topic in the current time is immense, given the efforts and measures from the all walks of life and every single crevice of the world to create a cohabitat for every living form that is sustainable and congenial for every life form on this planet. So first things first, what are these sustainable development goals? These SDGs are also known as the global goals, are a universal call to action and to end poverty, protect the planet, and ensure that by 2030, all people enjoy peace and prosperity. This is a common agreement to commitment from all countries to prioritize progress for those members who are furthest behind. The creativity, know-how, technology, and financial resources from all of the society is necessary to achieve the SDGs in every single context. All goals have to be achieved. All goals have to be achieved in each region and in each country. Otherwise, these SDGs would remain unfulfilled. To set the premise, the SDGs built on decades of work by countries and the United Nations, including the UN Department of Economic and Social Affairs. So in June 1992, the Earth Summit in Rio, Brazil, more than 178 countries adopted what is called as the Agenda 21, which is a comprehensive plan of action to build a global partnership for sustainable development, to improve human lives and to protect the environment. Then in the year 2000, member states unanimously adopted the Millennium Declaration at the Millennium Summit at UN headquarters in New York. We all know that these are called as the Millennium Development Goals to reduce extreme poverty, and the target year was set at 2015. After the success of the setting of these MDGs, going further, in 2002, the Johannesburg Declaration on Sustainable Development and Plan of Implementation, adopted at the World Summit on Sustainable Development in South Africa, reaffirmed the global community's commitment to eradicate poverty and on the environment, and it built on the Agenda 21 and the Millennium Declaration by including more emphasis on multilateral partnerships. At the United Nations Conference on Sustainable Development, that is Rio +20 in Rio, Brazil in June 2012, the member states adopted the outcome document, that is the future we want, in which they decided inter alia to launch a process to develop a set of SDGs to build upon the MDGs and to establish the UN high-level political forum on sustainable development. The Rio +20 outcome also contained other measures for implementing sustainable development, including mandates for future programs of work in development, financing, small island developing states, and many others. In 2013, the General Assembly set up a 30-member open working group to develop the proposal on SDGs. And finally, in 2015 January, the General Assembly began the negotiations to process on the post-2015 development agenda. The process culminated in subsequent adoption of the 2030 Agenda for Sustainable Development, with 17 SDGs as its core at the UN Sustainable Development Summit, which happened in September 2015. 2015 also happens to be a landmark year for multilateralism and many international policy shaping, with adoption of several major agreements, including the Sendai Framework, that is for disaster reduction, the Addis Ababa Action Agenda for financing, of course, the Sustainable Development Goals, and also we had the Paris Agreement on climate change over the course of the same year. Now, the annual high-level political forum on sustainable development serves as the central United Nations platform for follow-up and review of these SDGs. So, as I said, there are totally 17 SDGs. I'll read each of them. The first one being no poverty. Goal 2 is zero hunger. The third is on good health and well-being. Goal 4 is about the quality education. Goal 5 being gender equality. The sixth goal is on clean water and sanitation. The seventh is on affordable and clean energy. 8 is decent work and economic growth. 9 is on industry, innovation and infrastructure. 10th is on reduced inequality. 11th on sustainable cities and communities. 12th about responsible consumption and production. 13th on climate action. 14 addresses the life below water, and the 15th on the life on land. 16 is for peace and justice with strong institutions, whereas the 17th vies for partnerships to achieve all the goals. We have to understand that all these 17 SDGs are integrated and interconnected, and they recognize that action in one area will affect the outcomes of others, and the development must balance social, economic, and environmental sustainability. No goal is more important. No goal is less. Of these, only the SDG 2 clearly mentions the concept of nutrition, but is it where the focus on nutrition ends in these goals? Let us try to figure it out. So among these 17 goals, I would like to pinpoint 3 goals that I feel are directly in relationship with and impact they have on public health and nutrition. These are goals 2, 3, and 6. Let us have a deeper look into these 3 goals individually. The second goal of SDG is to end hunger, achieve food security, and improve nutrition, and promote sustainable agriculture. In this, the first target is ending hunger and ensuring access by all to safe, nutritious, and sufficient food all through the year by the year 2030. The key indicators that would be used as a yardstick to measure progress in this goal are: 1, prevalence of undernutrition, and 2, prevalence of moderate or severe food insecurity in the population, which is based on the Food Insecurity Experience Score, the FIES score. The second target is that by 2030, we should aim to end all forms of malnutrition, including achieving by 2025 the internationally agreed targets on stunting and wasting in children under 5 years of age, and address the nutritional needs of adolescent girls, pregnant and lactating women, and of the older persons. The indicators for this goal are estimating the prevalence of stunting among children under 5 years and the prevalence of wasting and obesity among children under 5 years. The third target is, the third indicator is to look into the prevalence of anemia in women aged 15 to 49 years among pregnant. Third target is by 2030, we have to double the agricultural productivity and incomes of all food producers, particularly women, indigenous people, and the deprived. The indicators of this target include volume of production per labor unit by classes of farming, and the average income of small-scale food producers by gender and their indigenous status. Various other targets are also there in this goal, which are not very directly related to nutrition. Nevertheless, they have an important impact on the food and nutrition security of the masses. If we see how Goal 2 has progressed over years, between 2014 and the onset of pandemic, that is 2020, the number of people going hungry and suffering from food insecurity has been gradually increasing. The share of countries burdened by high food prices, which had been relatively stable since 2016, they have rose sharply from 16% in 2019 to 47% in 2020, reflecting mainly the trends in international markets. In 2020, between 720 to 811 million people worldwide were suffering from hunger, and which was as many as 161 million more than what was the situation in 2019. Also in 2020, over 30%, or a staggering 2.4 billion people, were moderately or severely food insecure, lacking regular access to adequate food. This represents an increase in almost 320 million people in the course of just 1 year. And globally, 149.2 million children under 5 years of age, or 22%, were suffering from stunting in 2020, the proportion of which has decreased from 24.4 in 2015. But to achieve the target of a 5% reduction in the number of stunted children by 2025, the current rate of decline at 2.1% per year, it should be doubled through global efforts to at least 3.9% per year. In 2020, the wasting affected 45.4 million children under 5 years of age, which was 6.7%, and overweight affected around 38.9 million children under 5 years of age, which was around 5.7%. All these percentages would be even more worse in India. Wasting alone will be one of the conditions which will be most impacted by the COVID-19 pandemic in the coming short period of time. And about 15% more children will be suffering from wasting owing to deterioration in the household wealth and disruptions in the availability and affordability of nutritious food and essential nutrition services. Since 2015, the anemia situation in women of reproductive age has remained stagnant globally, with over 500 million women were anemic in 2019, representing a prevalence of nearly 30%, with 29.6% among non-pregnant and 36.5% among pregnant women. If we see how the decline has been over the years in India, in the proportion of undernourishment, which is calculated as the gap between the requirement of calories and actual adequate intake, India's progress has been very low. In fact, it was 18.4% in 2000, which has come down only to 16.3%, considering that countries which have started at the same or even worse level to it at 2000 have shown tremendous improvement, and some of them being our own neighbors like Myanmar, which has shown improvement from 37.6% to 3.1% in the same time, Mongolia 31 to 3.6%, and Armenia 26.1 to 3.5%. In fact, the top 11 countries with highest improvements have all started at the same level or worse level than India in 2000. If you look at the wasting prevalence, has only increased in India from 17.1% in 2000 to 19.3% in 2022. During the same time, there have been so many countries which have shown tremendous improvement, significant decreases like the Democratic Republic of Congo from 15.9 to 6.4%, Nigeria from 14 to 6.5, Laos from 17.5 to 9, Djibouti from 19.4 to 10.1, and Cambodia from 17.1 to 9.5%. Again, about 27 countries around the globe have reduced wasting by more than 50% of their 2000 levels, whereas during the same time, India's wasting has only increased. If we look at the status of stunting, India has shown a good decrease from 54.2% to 35.5% between 2000 and 2022. which is a 34.5% relative decrease. In the same time, DPR Korea had moved from 51 to 19.1%, Bangladesh from 51 to 28%, Nepal from 56 to 31%. And they all have shown better results. I'm comparing the countries which have started almost similar or worse than India at 2000. And all this data is from the recent Global Hunger Index back data. And during this time, about 23 countries world over have reduced their stunting by more than 50% of their 2000 levels. So what are the hindrances? What are the bottlenecks that have been affecting the achievement of goal 2? I'm talking about the global scenario. One, the COVID-19 epidemic has pushed the rising rates of all forms of malnutrition even higher. The conflict situations like the war in Ukraine is further disrupting the global food supply chain, and it is being said that it is creating the biggest global food crisis since the Second World War. And climate change is another important issue that has augmented the rising inequalities in food availability. Moving on to goal 3, which is ensuring healthy lives and promote well-being for all at all ages. Under this, the first target is to reduce the global maternal mortality ratio to less than 70 per 1 lakh live births by 2030. The indicators used for this are the MMR and the proportion of births attended by skilled health personnel. The target 3.2 is to end preventable deaths of newborns and children under 5 years of age, with all countries aiming to reduce the NMR to at least as low as 12 per 1,000, and the denominator will be 1,000 live births, and the under 5 mortality to at least as low as 25 per 1,000 live births. The indicators to be used are the under 5 mortality rate and the neonatal mortality rate. The third target is to end the epidemics of AIDS, tuberculosis, malaria, the triad called as ATM, and other neglected tropical diseases, and also to combat hepatitis, waterborne diseases, and other communicable diseases. The indicators are the incidences or new cases of HIV, tuberculosis, malaria, hepatitis B, and also the number of people requiring interventions against the neglected tropical diseases. The fourth target is to reduce to 1/3 level all the premature mortality which is happening due to non-communicable diseases through prevention and treatment, and also to promote mental health and well-being. The indicators under these are the mortality rate attributed to the CVDs, cancers, diabetes, and chronic respiratory diseases. And the second indicator is the suicide mortality rate. There are other targets also under goal 3, which are remotely related to nutrition and health, like the substance abuse, road traffic accidents, access to reproductive sexual health care services, quality and affordable healthcare services, and deaths due to hazardous chemicals, etc. If we look at the progress in goal 3, there has been in 2022, 84% of births worldwide were assisted by skilled health personnel, which was an increase from 77% in 2008-2014. And the global under 5 mortality rate fell by 14% from 43 deaths per 1,000 live births in 2015 to 37 deaths per 1,000 live births in 2020, while the global neonatal mortality rate fell from 17 in 2000 to 2020 from 19 in 2015. This is as per 1,000 live births, and this is a relatively smaller fall of around 12%. For the first time in a decade, there was a rise in tuberculosis deaths, mostly attributed to the COVID-19 pandemic and its devastating effects. And from 1.2 million in 2019 to 1.3 million deaths in 2020. And these deaths exclude tuberculosis deaths among people with HIV. There was an estimated 241 million malaria cases and 627,000 malaria deaths worldwide in 2020. Again, there has been an increase from 14 million. It was 14 million more cases and 69,000 more deaths in the past 1 year. If we look at the child mortality rate in India from 2000 to 2022, it has fell from 9.2% to 3.3%, taking leverage mostly from the falls in the infant mortality rates. And this is a 64% improvement. And looking at the falls in the infant mortality rate, these rates are bound to decline even further. And this is one area where India is performing on par with the other global as well as our own neighbors. And there are 13 countries world over which have reduced their child mortality rate more than 75% from their 2000 level. So looking at what are the bottlenecks, again, the pandemic has severely disrupted the essential healthcare services. It has shortened the life expectancy, has exacerbated the inequalities in access to basic healthcare services between the countries and people, and it is threatening to undo the years of progress in several of our healthcare areas. The migrant crisis, conflicts elsewhere in the world have accentuated this scenario, and the global economic slowdown will start showing its effect on public health spending. Today, we see many countries, though they proportionately show that their public health spending is on par or it has increased, much of it is attributable to the COVID-19 vaccinations. Access to safe water, sanitation, and hygiene is the most basic human need for health and well-being. It is an important contribution towards health and subsequently also on the nutrition of human beings. The SDG 6 and its 2 targets also indicate the same. These targets are achieving universal and equitable access to safe and affordable drinking water, monitored by the indicator of proportion of population using safely managed drinking water services. And the second target is to achieve access to adequate and equitable sanitation and hygiene for all, the indicator being proportion of population using safely managed sanitation services and hand washing facility with soap and water. So between 2015 and 20, the proportion of population using safely managed drinking water services has increased from 70 to 74%, and the population with safely managed sanitation increased from 47 to 54%. But this rate needs to quadruple if the goal of universal coverage are to be met by 2030. For at least 3 billion people out of the currently living 8 billion people, 3 billion people, the quality of water they rely upon is unknown owing to lack of monitoring. The demand for water is rising owing to rapid population growth, urbanization, and increased water needs for agriculture, industry, and energy sectors. Decades of misuse, poor management, and over-extraction of groundwater, contamination of freshwater supplies have exacerbated the water stress globally. In addition, countries are facing growing challenges linked to degraded water-related ecosystems, water scarcity caused by climate change, underinvestment in water and sanitation, and inefficient cooperation on transboundary waters. Over the past 300 years, wetland ecosystems have experienced 85% loss in extent, despite they being sources of very high value goods and services. The extent of surface water bodies like lakes, rivers, and reservoirs is rapidly changing across the planet, with 1 in 5 river basins experiencing high fluctuations in surface water during the last 5 years. While the above 3 goals have a very direct bearing on nutrition and health, most other SDGs also have their own relevance in public health nutrition. Like Goal 1, poverty limits access to adequate food intakes and makes it difficult to reach nutritional recommendations. Reduced poverty is directly relevant to improve nutrition as it improves the affordability. Poverty, a good quality of education always it has a bearing on better nutrition. It improves the childcare services and also the health-seeking behavior. On the other hand, if we see malnutrition affects quality education as it decreases the scholastic ability. Goal 5 is about gender equality. An empowered woman at house translates into better nutrition choices, improved food intakes, and better child health, including improved IYCF practices. Particularly in low and middle income countries, women and girls are essential to agricultural laborers. They are also often the ones who are in charge of preparing food and taking care of health of their families and communities. If their knowledge and skills are improved, they can contribute to improved nutrition and healthier societies. Empowering women to claim their rights lead to improved quality of life as well as improved nutrition. Again, we have to look at the other way around. The proper nutrition improves learning performance, which can be translated into better job opportunities and better gender equality. Employment and country's economic growth leads to improved affordability, increased public health spending on health and nutrition, and also the economic transformation will provide improved access to nutrition security and sustainable agriculture. A looming refugee crisis is adding up to the global burden of food insecurity. While it directly affects the affordability and availability of food, it also causes a double blow on the health system of the countries, which again add up to the nutritional crisis. The problem is not just on the refugees, but also on the country that they take refuge at. It pains to see that on one hand, we have acute hunger, and on the other hand, there is a lot of food wastage. It is estimated that nearly 30% of the food goes to waste without reaching to the mouth of the consumer. Agricultural production and food demand patterns are causing climate change and reduced biodiversity, which is in turn reducing the food availability. Meeting the nutritional needs of a growing global population requires sustainable solutions for food production and access to water, as uncontrolled and inefficient food production causes greenhouse gas emissions and further soil degradation. Climate change hampers global food production and food security, as well as the access to fresh water resources. It may lead to sudden onset of disasters and droughts, which lead to acute nutritional deprivations. Climate change can also influence other goals like SDG 2, SDG 6 on WASH, SDG 12 on sustainable production, apart from SDGs 13 and 14. To summarize, let us see how each of the goal is relevant in various aspects of nutrition. If we look at what are all the factors that affect the food intake, they have been mapped. And if you see goal 1, each of the goal acts at various of these factors, at different factors. So this should emphasize the relation of each goal to nutrition. Now that we have understood the importance of SDGs in public health nutrition, we will now try to see what are the strategies and intervention that have been identified for achieving the same. Many of these are already in vogue since a long time. And first, let us look at the strategic approaches that have been laid out. One is the life course approach, which has been dealt in detail in the previous session. So our approach should start pre-conceptionally and it should end at the deathbed. all across the life, our intervention should take place. Next is health in policies approach, where the progress of ending malnutrition in all its forms depends on actions not just on the health and nutrition sector, but various other sectors like agriculture, environment, social protection, education, transport, infrastructure, public procurement, trade, and finance. The list is unending. And it also, the adoption of an integrated multi-sectorial approach, viewing health and nutrition in all of these is necessary. This is about health in all approach. We have to involve whole of the society as an approach, like not just the sectors which we have previously enlisted, various other sectors like the civil society, panchayat, academia, media, etc. also have their own bearing on achieving these goals. Addressing determinants of health and nutrition. As we have seen, there are so many factors which are affecting health and nutrition, and considering that malnutrition is multifactorial, the nutritional actions should address these social, economic, and environmental determinants separately. Our strategy should be anchored in a human rights approach, wherein every man, woman, and whatever is the gender identified, the child, and any person for that matter has the right to adequate food, nutrition, and health. And this right has to be upheld in every level possible. This approach has to be implemented. Knowledge sharing and exchange of experiences from one country to the other and within the country need to be done with regional cooperations. There is a clear need to share experiences, and the experiences need to include not just successes, but also failures, so that the failure models are not replicated elsewhere and the resources are wasted. Next, moving on to the key areas of action, which were identified at the United Nations Decade of Action on Nutrition. These are sustainable, resilient food systems for healthy diets, aligned health systems for providing universal coverage of essential nutrition actions, social protection and nutrition education, trade and investment for improved nutrition, safe and supportive environments for nutrition at all ages, and strengthen nutrition governance and accountability. We'll try to look at each of them. The specific intervention in each would be an unending list. So in view of time, paucity of time, I'll be only mentioning the key actions under each of them. Please note that this list is not exhaustive. The burden of malnutrition is closely related to the state of today's food systems. While changing patterns of food production, processing, and marketing have added in reducing hunger by improving the availability of food and also its cost, it has not translated in the improvement of access to diverse and micronutrient-rich foods. Foods high in salt, sugar, trans and saturated fats have become cheaper and more widely available. Transformation of food systems is therefore needed so that nutritious, safe, affordable, and sustainable diets are available to all. Strong and resilient health systems have a key role to play in eliminating malnutrition in all its forms, and the actions would include building strong and resilient health systems, interventions to reduce stunting and wasting among children under 5, integrating health services policies and programs, and expanding nutrition interventions related to health services. Nutrition education and clear nutrition information remain important elements of any nutrition strategy. Measures to protect nutritional status of most marginalized, poorest, vulnerable, and the excluded populations in times of crisis and in long term are also needed. In today's globalized world, international trade has an important impact on nutrition. They should try to focus on imports that will target nutritional improvements as much as the food security. There is a need for countries to work together and across sectors, learning from others' experiences within and beyond the neighborhood to identify the opportunities and risks for nutrition associated with the trade policy and to implement complementary policies to offset any risks which are identified. There has been an increased recognition in recent years of the crucial role of supportive environments in improving the nutrition status. The environments in which we buy, choose, prepare, and eat food can influence what foods are available, affordable, and appealing, and can therefore have an important impact on the diets we consume. Investment in breastfeeding support, promotion, and protection is one of the most cost-effective and sustainable public health measures available, which was emphasized by our previous speakers. Improving their rates are therefore very prudent. A life cycle approach with importance to the first 1,000 years of life is very much essential to reduce childhood overweight and obesity, along with emphasis on physical activity. A multi-pronged approach is therefore necessary for the reduction of anemia, which is one of the important areas where there has still not been considerable improvements over the last few decades in India. Success in implementing this strategy will depend upon the extent of political commitment and the existence of an enabling policy environment, political stability, and effective government mechanisms. With this, I come to the conclusion of this talk with a hope that we cope up with the hindrances, continue the political will, and achieve the SDGs within the target year by utilizing the opportunities. I express my gratitude to the whole of the organizing team for such a wonderful session and for giving me a conducive space. Thank you, one and all.
Thank you for sharing your valuable insights with us, sir. I request Dr. Sunil Kumar D to hand over a token of appreciation to Dr. Raghavendra P. With this, we conclude the morning session for the day. We shall now break for lunch. Lunch is arranged below the guest house. So I request the delegates to join us back for the noon session by 2 p.m. Thank you all. Thank you, ma'am. Thank you very much, ma'am. Manjunath, sir.
Diet is not just what you eat. It is all about how you process it, how you cook it, how you store it, how long you store it, where you eat it, with whom you eat it. So this is what diet is. Last word from my side is, don't worry too much about diet. That's what I would like to say.
Thank you very much, sir. So I think at the end of this panel discussion, what I would like to conclude is culture and nutrition, the intertwining between the two, it depends on us ultimately. And that is what makes it a double-edged sword. And I think we have to keep the good cultural practices and I think ward off those which are not good. And I think that will make a lot of difference in our nutrition and definitely on our health. Thank you so much. Thanks a lot to everyone.
I would like to thank all the panelists for very informative session and valuable insights about the ever prevailing topic of culture and nutrition. I'd like to thank Dr. Smita MC for moderating the session and taking us through an interesting part. I'd like to request Dr. Smita MC to hand over the token of gratitude to the panelists. I would like to request Dr. Jamuna Prakash to hand over the token of gratitude to Dr. Smita. Thank you, ma'am. With this, we have come to an end of today's scientific sessions. Tomorrow at 9 o'clock, we'll be having the technical session 3, that is on advances in nutritional research, followed by scientific presentations, oral and poster, and also a few competitions have been arranged. Then the technical session 4 is there, that is innovations in nutrition at 2 o'clock. At 3 o'clock, we have plenary session on public health workforce building resilient communities. Thank you one and all.